two methods. One is by filtration, but you use heparin. The other is centrifugation, which is better. It is based on density. There are two methods. One is intermittent, one is continuous, which is better. So what is the principle? So the blood comes, it rotates, and you get back plasma, white cell, red cell. And this is the way. So the lowest density specific gravity is of plasma, which separates. Platelets and other cells will settle down. So you remove this. Now, how do we use for liver patients? In acute liver failure, therapeutic plasma exchange has category 1A. I will come to it. You can also use in HLH or DILI 2B, 2C. With multi-organ failure 2A. Of course, in ABO incompatible, all of you know, so I have not highlighted it. Wilson's you can use it in porphyrias, pruritus and vasculitis. My topic is of ALF. So in the guidelines of 2023, you will see that it is given 1A category in ALF as a therapy for plasma exchange. Managing ALF has challenges. Acute liver failure, generally 70% will have cerebral edema, hemodynamics are deranged, SIRS is present, you have DAMPs, cytokines, toxins, and sometimes multi-organ failure. Hemodynamics is the cerebral perfusion pressure. Please remember this, cerebral perfusion pressure is low. And in hemodynamics, cardiac output is increased due to hyperdynamic states with a low SVR, peripheral vasodilation. It is like a vasodilatory shock. Now, intracranial hypertension, see the amount of ammonia, and Professor Acharya has done seminal work. Higher ammonia, the blood flow increases. So 400 ammonia, you don't have to do blood flow, just think it is about 120 ml per 100 gram per minute. Now, if you have 120 ml of cerebral blood flow per minute, your intracranial pressure is about 45. You have increased intracranial pressure and you have more of TNF and other cytokines. So, ICP is related to ammonia, which causes increased blood flow, intracranial hypertension. Now, you do plasma exchange. Plasma exchange increases cerebral blood flow, so don't forget it. So, this is a negative factor of plasma exchange. But the good point is, it also increases cerebral perfusion pressure, but at a cost. Oxygen extraction and intracranial pressures by and large remain unchanged. This is also Larson's original work. So, why should we do plasma exchange? Detoxification, biosynthesis, homeostasis. So, you remove toxins, you get some regeneration. This is a thought which is not correct also. And homeostasis. Now, hepatic blood flow and splanchnic oxygen consumption. Now, plasma exchange causes increased hepatic blood flow. So, your blood flow, this is 0 and this is endothelin 1 or even 3. So, now your blood flow increases after plasma exchange. Once it increases, your endothelin, which is a vasoconstrictor, also increases. So, all these are things, just don't do plasma exchange like you are giving blood transfusion. Remember, each of these has a relevance. Increase endothelin, more vasoconstriction, less nitric oxide. Now, half volume, 1 volume, 2 volumes. Half volume, this shows you fraction of intravascular substances which are remaining after half volume plasma exchange. After 1 volume, you have removed 63%, which to me is good. Some people want to do high volume, which is 2 volumes, you remove 14% remain, 86% removed. But that may be sometimes challenging. Why? Now, you are doing plasma volume on day 1, your IgG comes down on day 1. Then slightly body makes it, again comes down. By day 3, With single volume, you are reducing your IgG levels tremendously. It comes down to 20% of your normal IgG. So remember, single volume may be better than two volume. Of course, high volume plasma exchange 2 volumes will decrease ammonia, but how much? Maybe 50, 100. It will come back again. So just don't target ammonia. Remember every single consequence of that. Now this study, which is the basis of giving it a 1A category to get into guidelines, was done by Larson over 15 years or so. This is a high volume plasma exchange, 2 volumes versus 1.5 to 2 standard therapy. Survival by the end of 3 months is 58% or 47%. This was not significant. It became significant only when those who got transplanted were excluded, which is not the best way. So in general, high volume did not improve the survival. What it definitely did was improve the inflammatory markers. Now this study, which was done by Dr. Rakhi, very elegantly, 126 patients of ALF, all of them who had cerebral edema were included for standard volume, means 1 volume, and standard medical therapy. So 20 patients. One went for transplant, 4 died, 11 died in this. Now see some of the interesting aspects. The amount, what you can see is clearance of ammonia, lactate, hemodynamics, and SOFA score. This is over a period of time. Standard volume versus the standard of care, there was a benefit. Sorry, I can't read so well in this. What is interesting is plasma exchange reduced pro-inflammatory cytokines, IL-2, 17, 1-beta, MIP, IL-6. It also improved some of the anti-inflammatory markers here. What was a big loss was regenerative factors like GCSF, PDGF were also removed. So what plasma exchange did, anti-inflammatory improved, pro-inflammatory decreased, but it cleared regenerative factors to me, which was a negative point for plasma exchange. Endotoxin levels. Plasma exchange from baseline to day 5 improved or reduced endotoxins. It also removed DAMPs, HSP 70, 90, HMGB1 and all others. So DAMPs are decreased. A very interesting thing, and plasma exchange repaired your endothelium to some extent. What it did was it reduced von Willebrand factor and improved your, so von Willebrand factor after plasma exchange is reduced, and the thing which breaks down the ADAM-TS levels were also simultaneously changed. So the ratio is reduced. It is suggestive of a better endothelium. Ultimately, the study of 20 patients versus 20 showed standard volume plasma exchange improves survival, though marginally, but it gives us. So now we are using this as a routine process. So just to summarize, you have liver injury. Because of liver injury, Kupffer cells, inflammation, and you have DAMPs, and all these are suppressed by plasma exchange. ADAM-TS, von Willebrand factor repaired. You also have monocyte back to energy. I will show you that. Cerebral edema, AKI, cardiac dysfunction could be prevented. But it's not panacea. This is a study done by Professor Seema Alam from ILBS, which showed that in Wilson's disease presenting as ALF, it improves survival. Now, this is a study done by Dr. Satyam. I forgot to put his name. He was the first author as a DM resident. Here, plasma exchange versus standard therapy, bilirubin. From baseline of 23, day 7, it decreased it to half. INR improved, and bile acids, which I think is the worst thing for hyperdynamic circulation, decreased from 300 to almost 95 by the end of it. So bile acids are the ones which cause maximum injury. So plasma exchange removes it. Let's now go to, that was ALF, we go to ACLF. In ACLF, you have again removal of the toxins so that you can prevent death, stimulation of regeneration, which is marginal, and immune homeostasis. To me, this is the most important part, because and I'll show you how immune homeostasis comes. These are simple 3 studies. It shows you mortality in this meta-analysis shows better survival in ACLF. This landmark study done by Professor Appen shows in severe alcoholic hepatitis, you do plasma exchange and add low dose of steroids, it improves survival. Now, hemoperfusion is something which can be used, which removes, it's a filter, bilirubin and bile acids. It's very expensive. Plasma exchange is not that. They are generally same, but plasma exchange, organ failure is about 20%, 33%, and the heme absorption, this is less. Organ failure rates are slightly low, but survival is not better. We also looked at bilirubin and bile acids. There was no major difference. So instead of using very expensive filters, in the common setting, you can use plasma exchange single volume. Now here Prometheus was compared, and as compared to Prometheus, the plasma exchange gave better survival at 90 days. Now I'll briefly touch this very interesting area which might excite you, kinetic changes in monocytes, bioenergetics in ACLF. Now in ACLF you have, because of the injury in a cirrhotic liver, DAMPs and PAMPs, over a period of time, the cells in 24 hours have low glycolysis and low oxidative phosphorylation. And there is a functional exhaustion of neutrophils in about 12 hours, monocytes in 24 hours, dendritic cells in 24 hours. How do you restore this? To restore this, you can do a umbilical cord M.I.C.E. therapy. It can restore by giving the mitochondria directly to the monocytes. This is not possible. How do you get this monocyte back into function? Let me show you. So this is a seahorse machine which gives you readout of oxygen consumption rate of individual cell type or glycolysis rate. Now this is the basal respiration of the cell. Now if you stimulate this cell has this reserve capacity. I am not going into blockers, but every cell has this reserve capacity. This reserve capacity is finished in ACLF. Now there are 2 patients here. This is a baseline patient, then 24 hours, then 72 hours. Now this patient has an OCR which should generally be about 100 plus, has already half the oxygen consumption rate. But once plasma exchange was done, his OCR goes to 100. This patient will survive. The second patient here, who has a very low baseline, the green one is baseline, oxygen consumption rate does not improve with plasma exchange. This patient will die. So at the end of 6 hours, if you see monocytes have improved in their oxygen consumption, the patient can be told. So now very often we try to say whether the patient's monocytes can be rejuvenated. My last slide. There are other challenges with plasma exchange. It removes high molecular weight substances which are above 50,000 kilodaltons. Dialysis does not, but plasma exchange removes. So it removes all the cytokines, growth factors, beneficial immunoglobulins like IgG, coagulation factors, complements, it removes antibiotics, and of course can cause TACO and TRALI. So please be careful when you use the plasma exchange. So to carry home message is, plasma exchange is generally safe and effective in ALF, somewhat in ACLF. It is very good for viral etiologies, Wilson's, DILI, and of course in alcohol in acute and chronic liver failure. It prevents complications like cerebral edema and others, can correct coagulopathy. But remember, it's not a replacement for definitive therapy. With this, a just brief reminder for Apostle 24 and a meeting on liver cancer being organized by Ashok in October. Thank you for your kind attention.
Thank you for the excellent presentation, sir. Question, please.
Sir, regarding that monocyte mitochondrial function improvement, is it specific to the monocyte?
We have studied monocytes. We are studying now the oxidative burst phagocytic functions in neutrophils. But for monocyte, which is the father for all the other things, it is very, very specific. It's very good.
You mean as a predictor of survival?
Yes, as a predictor of survival. Because all the HLAs are lost.
So you are suggesting that because of plasmapheresis, in some patients, the mitochondrial function in the monocyte improves, in some others it doesn't.
Yes.
Why that happens, we don't know.
Probably they are late, they have too much load. We don't know the reason, but it is a fact in which OCR improves survival.
Thank you, sir. Really enjoyed that talk. The query that I had, you pointed out that plasma exchange results in depletion of hepatocyte regeneration factors and possibly impairs regeneration. So how does that guide your plasma exchange therapy?
Yeah.
Will you step down after a certain time, or the liver regenerates despite your depletion of hepatocyte growth factors, number one? And the other thing was that CRRT for ammonia clearance and plasma exchange sequentially or in the same patient, have you tried that, and what would be your comment on this using these together?
Yeah, the regenerative factors certainly are lost, and my most worrisome is C3 and C5, they are lost. Sometimes I feel half volume may be better. It's better to remove 30%, 50, 40% than to remove 60% or whatever. But I am not scientifically sound on this. But yes, IL-6, TNF-alpha and several others are lost in the process. So how to repair that, I have no idea. But I would say plasma exchange every day is not still the best option. It is just a bridge. Now CRRT is done, but I rarely find it achieves the targets of reducing ammonia to that level. I think ammonia is produced because your bowel is like a box and the bacteria keep producing ammonia and you don't have motion. So to me, CRRT is good to reduce intracranial pressure, but it's probably not that helpful. But we are using it because there is nothing better.
Well, see, both Larson study is a simple clinical question. Was done in 12 years in 3 centers.
Yes.
You remember, they are not consecutive patients.
No.
Many of these patients are paracetamols.
Yes.
And they have received also the drugs, which is not corrected. Plasma exchange anyway will clear things in plasma. That is nothing surprising to show that, right? And when you are doing a plasma exchange, you are also replacing the volume with systemic vascular resistance. So the hemodynamic parameter also will improve. Now even Raki studies, the difference is very small. It is a statistical difference. Now question is, in our setup, many of the patients with viral hepatitis with intensive care unit will spontaneously improve. Right. And plasma exchange may be just adding or not adding at all. Because if you see Raki studies, the sample size is 20. Now if you see spontaneous survival in them is about 50% today with ICU care. Now to improve by 10%, you need a large sample size. Right.
I agree with you.
That's one problem. The second problem in Larson, they are select patients. Yet, we are giving a grade 1 evidence and conveying that plasma exchange is fine. I have simple clinical question when I saw this study. And exchange will change everything.
I agree with you totally because the Larson study has been overrated, kind of given weightage for being study first, of its kind. However, now we are using it, and you are right, if you have to have 10% increase you need a very large sample size. And we are doing it because there is no other way. But I think at least one plasma exchange, may not be 2 or 3, in the beginning probably helps. ONSD decreases, patient gets better. So now it's almost a standard protocol, but we need to move higher up. We need to do more studies, maybe national collaborative study or so.
So just one additional slight clarification. Did you also face a problem of infections following plasma exchange? That does that make the person already ALF is very vulnerable to infections, and adding and clearing all the IgGs would that worsen the infection is one. And I think the end point, how long do you continue plasmapheresis? Is it till recovery? Is it till transplant? Or there is some fixed end point at which you stop plasmapheresis or plasma exchange?
Yeah, it does not, in ALF, does not add much to infection. In ACLF, yes. In ALF, only thing is because sometimes the patient has refractory hypertension and you are giving NTG drips. If the patient is on NTG drip and also has plasma exchange, outcomes are not very good in my mind. So NTG should be avoided. How to handle the intracranial hypertension is difficult because hyperammonemia, hypernatremia and hypertension will persist. As far as endpoint is concerned, we sometimes go up to 4 or 5 sessions. My personal preference is if the regeneration doesn't pick up in 4 or 5 days, LT should be considered, and 3 to 4 days is a good time for getting the donor. After 3 or 4 sessions, it may not make a huge difference. Certainly.
So, any role of plasmapheresis in hepatitis A or B related prolonged cholestasis with pruritus, intractable pruritus?
Yeah, I mean, that is a very good question. We all do it because patient, like yesterday we had one with 57 bilirubin itching, drug induced, or another one is hepatitis A. It works, it's very good. So you can use it. Since it was not ELF, I did not mention it. I think it's a good choice to remove damps and others. You can use it.
Thank you, sir.
Thank you.
Next session will be on Budd-Chiari syndrome, when and how to intervene, and Dr. Shalimar will be speaking on it.
No, it's very difficult to follow a master, so I hope I do some justice in my talk. At the outset, I'd like to thank Acharya sir, Professor Puri, for the kind invitation. Okay, so this is Budd-Chiari syndrome, or what we also known as hepatic venous outflow tract obstruction. Obstruction anywhere where the hepatic veins are formed when they drain into the IVC till the time they drain into the atrium. This is what we collectively know as hepatic venous outflow tract obstruction. Coming to the clinical presentations, as in any other liver disease, we've got a fulminant presentation, you've got an acute, a subacute presentation. Fulminant is ALF, uncommon, though these patients will have. In contrast to a typical ALF, a tender hepatomegaly, you'll have encephalopathy, liver enzymes very high. Acute presentation would have also tender hepatomegaly, but will plus minus have hepatic encephalopathy. Liver enzymes will not be very high, and this presentation is usually within 4 to 6 weeks. Subacute is what we typically see in our clinical practice. Most patients present with cirrhosis and its complication. You'll have hepatosplenomegaly, ascites. Presentation varies from 1 to 6 months, and for the chronic, it's more than 6 months. This is what you'll see when you see a patient. You'll have dilated veins. More importantly is look at the back of the patient. You'll find dilated veins on the back also. You'll have ascites, and you'll have leg ulcers. It's typically more seen in IVC obstruction, where you see these big ulcers. Take-home message for everyone: Budd-Chiari syndrome, in contrast to a decompensated cirrhosis. Hepatomegaly, over here it's the liver which is small in size, dilated veins of back. Liver function tests are normal, platelet counts are high. In contrast, platelet counts are low in cirrhotics, garden variety cirrhosis, you got a high protein, high SAG ascites, and you got probable predisposing factors in terms of hypercoagul states. Okay, how do you diagnose? You can use a simple ultrasound and a color Doppler. A venography, either a CT or an MR or a conventional venography can be used. This is how a Budd-Chiari looks like on an ultrasound. You'll have dilated veins. You've got veins which are not seen well in caliber. When you do a Doppler, you may see there is an obstruction. That means, look at these hepatic veins which are dilated. This is the IVC, and there is a break in between. That means the HVs are not draining into the IVC. You'll have long segment occlusions, no hepatic vein is seen, and this is what typically you'll see is a comma-shaped collateral. What do you see on CT? This is what we were taught by Professor Acharya when we sat with him in the clinic. This is a mottled or a variegated preponderance. You see this on CT, it is almost diagnostic, or it's a diagnostic of any venous obstruction. But this is typically what you'll see. And so this carry on message, you see this mottled appearance, suspect Budd-Chiari. You'll see other appearances in form of various nodules, NRH, and even tumors can develop in these patients. You do a venography, you see that the IVC is narrowed over here, dilated in this part, and this is where it's draining into the atrium. And when you see over here, there's the same picture showing that there is narrowed. This is what you see on a venogram. On a hepatic venous venography, you'll see this is what is typically what we call as a sinogram. What you do when you do an HVPG, where you're blocking the catheter, and similar picture is seen in a Budd-Chiari where the hepatic vein is blocked, and you see the sinogram pattern, and this is what you'll see is multiple collaterals. Natural course, we all know presentations could be as what I mentioned, as ALF, as subacute presentations, chronic and ACLF, and these patients may present to you clinically with ascites, bleeds, encephalopathy, and HCC. So if you intervene, you may change the natural course. How do we intervene and when do we intervene? Interventions are symptomatic treatments. You need to treat as you're treating in any chronic liver disease, treatment of varices, ascites with diuretics, treat the underlying hypercoagul state, relieve the obstruction, and consider screening. So this is no very different from any garden variety cirrhotic. But yes, there are certain things which you need to keep in mind while managing a BCS patient. Medical management, every patient would need this. Would I treat a particular patient only with medical management? Yes, a certain group who do not have any symptoms, incidentally detected, has lots of collaterals, and no varices. Yes, that group can just be maintained on medical therapy. But then, if you treat a garden variety Budd-Chiari with medical management, you're expecting a poor outcome. So this is not a management recommended in isolation for managing Budd-Chiaris. Anticoagulation, yes, because they have a hypercoagul state. You are doing any kind of intervention, they need a treatment with an anticoagulant. We'll come to that, but do remember anticoagulants do also have some side effects. So you can't just put a patient on anticoagulant and send them back home. They may come to you with mucosal bleed, GI bleed, intracranial bleed, and even pulmonary hemorrhages. Workup for prothrombotic states is important because you got specific treatment for myeloproliferative disorders, APLA and PNH. Rest of them, it doesn't matter because you're going to treat them with anticoagulants. So whether they have, don't have, the treatment doesn't differ. Behcet's is another predisposing factor. Do ask for history of pills. Pregnancy is something which you see that post-pregnancy or during pregnancy, you may have presentations of Budd-Chiari syndrome. So how do we relieve the obstruction? We do it either radiologically or surgically. Radiologically, you do with angioplasty or stenting, and you consider TIPS in these patients. So what is the strategy? You do a Doppler, you know where the site of block is. We talked about the site of block could be in hepatic vein. So if you have obstruction in the hepatic vein, it depends whether it's a short segment or a long segment. Short segment, you can just get away with angioplasty, or you can add up stenting to it. If that is long segment or all three hepatic veins are blocked, you need to consider either TIPS or DIPS. When no hepatic vein is seen, you do a DIPS. IVC, first intervention is always a single angioplasty, And in the second, if the IVC angioplasty, the patient comes back again with symptoms or there is restenosis, you do a stent. You don't need to do an IVC stent at the first go. Combined blocks, you need to manage both the hepatic vein block and the IVC block. So let's see how do we do it. So I showed you the sinogram picture from the first leg. This is where the hepatic vein is blocked. This is where a balloon catheter is passed and the hepatic vein is dilated over here. And see, this is what happens on an angiogram. You can see the contrast flowing freely. This is where now you again see the same picture where there is an IVC block, a stent is placed, and this is what we see post-stenting, that you see a very good flow and physiological flow is maintained in such a patient. Similarly, with an IVC block, where you see is now you can see there is a lot of collateral blood flowing from here. This is where the IVC and the blood should have flown from here to the atrium, and this is what a balloon angioplasty is done, and this is what happens post angioplasty of the IVC is you see the blood flowing from the IVC directly into the heart and the collateral is not seen now. Similarly with stenting, this is where a patient who's got an IVC block, a stent has been placed, and post-stenting, the physiological blood flow is restored back into the heart. So do we consider only angioplasty or angioplasty plus stenting? This is the only randomized controlled trial in Budd-Chiari syndrome, Chinese study, which shows that combination of angioplasty plus stenting helps maintain a stent or maintains patency of the vessel. So ideally, yes, a combination is better compared to angioplasty alone. TIPS is another modality, TIPS or DIPS, when the hepatic veins are not seen, where you put in a stent across from the hepatic veins to the portal vein and help restore the blood flow. And this is another way to manage a diffuse or a long segment block. Each procedure with Budd-Chiari comes with its own complication, and let me tell you, we've seen all of them. Hemoperitoneum, stent block, stent fractures, capsule breach, portal vein rupture, biliary puncture, hepatic artery puncture. So each of these you need to have an experienced radiologist with you. Coming to presentations with ALF, interventions possible. This group has a high mortality and only a small fraction of these patients can be intervened, but when you intervene, they are associated with good outcomes. Our own data in acute and chronic liver failure shows that when you manage such patients of ACLF with intervention, you can come to their outcomes with similar to those who got child C. In contrast, those who you do not intervene, they have a high mortality. A vascular intervention is associated with good outcome. Presence of encephalopathy is associated with poor outcome. Data showed from the UK group with Professor Eapen also showed that these patients have good outcomes with interventions. Outcomes are better across child states. So even child C should undergo an intervention as contrast to a garden variety of patients where you always consider for transplants. Technical success, our own data of 510 patients, which is one of the highest published across the globe, shows high technical success, 96% with clinical success also, and patency rates are good, 90% at 1 year and 5 year being 73%. Which anticoagulant to choose? We did a retrospective analysis of our patients treated with DOACs versus vitamin K antagonist, showing both of them to be equally efficacious. So a patient who doesn't want to come back and get his INR done repeatedly, dabigatran or other NOACs could be good alternatives with good outcomes in such patients. FibroScan could be a modality used for predicting restenosis. What we looked at in our analysis and showed that a rise in LSM post-intervention by 13% predicts restenosis. There are lots of prognostic scores which you can use, but then most of them have not been validated. We have also come up with our own score, but this still needs more validation across centers to see how it works in patients. Our own data suggests that patients with Budd-Chiari are predisposed to developing HCCs. Risk factors include cirrhosis, combined blocks, long segment blocks, and these patients can very well be managed where you can intervene both for the Budd-Chiari and for the HCC. Surgical shunts now are not commonly used because we've got radiological shunts which when created have been shown to have better outcomes to surgical shunts. Transplant's possible, but you need to consider these patients early before they develop renal failure, because if they develop renal failure, they have a poor outcome. And it corrects the underlying cause and should be considered. A common problem, pregnancy, or say not a common problem, but then when these patients have, then they have infertility, and then where you need basically a multidisciplinary intervention or way of management with your gynecologist and doing an intervention that probably might improve their fertility also. But we need more data for that. So when you're suspecting Budd-Chiari, do a Doppler. When you look at the type of block, you take a decision what you need to do. But important to say out here, IVC block, you can get away with just angioplasty and stenting. Hepatic vein blocks, again angioplasty and stenting, but TIPS is that what you need to consider. And for combined blocks, you take care of both the IVC and HV block. And if there is a failure, then always transplant is an option in such patient. There is a general principle which is being advised is follow a stepwise approach. I think it's more important to follow what is the best way approach rather than this stepwise approach. And you need a good team work for improving the outcomes of these patients. So just to summarize, Budd-Chiari has a distinct clinical presentation. These are young people who got hepatomegaly and ascites. Signs of liver failure are uncommon, although they do present. Diagnosis is based on imaging that includes an ultrasound, CT, or an MR venography. Blocks, most common are hepatic veins alone or in combination with IVC. Without radiological intervention, they have poor outcome. And it's a risk factor for HCC, and such patients should also be considered for surveillance. And multidisciplinary approach is the way to manage these patients. So with this, I'd like to end my talk. Thank you for your listening.
Thank you, Dr. Shalimar. Any questions from audience?
Excuse me, if following an intervention in Budd-Chiari, how do we go further? Because they say for 6 months we need to see the flow, how it is. What is your take on that?
So our policy is that when we do an intervention, the next day we do a repeat Doppler. And then after that, we call that patient at the first month, then at every 3 months. But the simple way clinically is when you do an intervention, ask the patient to monitor his body weight. So if he's got ascites, the ascites will resolve with time after intervention. And if there is a loss of weight, that suggests that patient stent is patent. And if he starts gaining weight, abdominal distension increases, pedal edema comes back, there is a problem. Doppler is the gold standard, or say is the best test to look for the stent patency. We as a policy repeat Doppler every 3 monthly in such patients. And we also do fibroscans because our own data suggests that if you find that once you do an intervention, fibroscan values comes down. If a rise occurs on follow-up, that should raise a possibility of a stent block. So that's how we follow at our place. Please, sir.
That's an excellent talk. I was wondering whether in a patient with a hypercoagulable state, only anticoagulants can be started as treatment option, or you have data on that? Some patients may not be willing for interventions. So, and only anticoagulants, and then follow up and see.
So I think that's what's there in the literature, but then it also suggests that these patients will have a poor outcome, because if you're not opening the outflow tract, there would be passive congestion. These patients will progress in their liver disease, develop cirrhosis, and have complications. So use of alone medical management includes diuretics and anticoagulants. In a group of patients who are asymptomatic, have collaterals, yes, can be considered, but then if they have symptoms, so my policy of way management, if they've got ascites, they've got varices, they need an intervention. Fibroscans high, they need an intervention. Yes, in a select group of patients who are not willing, you can keep them on follow-up, that can be done, but then they may fare poorly. We need more data on that. In isolation don't work. You need an intervention. That's very important. But sir, somebody like this is always a debate when we used to sit and ask is that somebody who has lots of collaterals, doesn't have varices, detected incidentally. We do get such patients. Then there is a debate, do we do a procedure? So, or we just manage them with just as follow-up with just medical management with diuretics and just anticoagulant. When they don't have varices, they don't have ascites, but they have lots of collaterals. That means spontaneously they have developed collaterals and they're draining. That's a little uncommon group, but that's one group where probable medical management can be considered. It's there, sir. It's there. It's there. But it's less than a garden variety cirrhosis. But then HCC does occur in bud caries. Thank you.
Thank you, sir. Now, next is the case discussion on IgG4 cholangiopathy. I invite the panelists to please come on the stage. Dr. Gordas Chaudhary, Chairman, Gastroenterology and Hepatology, Fortis Hospital, Gurugram. Dr. Vikram Bhatia, Professor, Gastroenterology and Hepatology, ILBS. Dr. Harshad Devar Bhavi, Professor, Gastroenterology and Hepatology, St. John's Medical College, Bengaluru. Dr. Pallavi Garg, Senior Consultant, Gastroenterology and Hepatology, Max Saket. I now invite the speaker, Dr. Mano, to please come. Dr. Mano is Principal Director, Gastroenterology and Hepatology at BLK.
Thank you, sir. So, to start with, there is a O missing in the cholangiopathy. I'm sorry for that. So, we have a very eminent panel here to discuss a problem which has come to fore these days, very lately, IgG4 cholangiopathy. A lot of talk has been there about this. We have a very eminent panel. We have our teacher, my mentor, Professor Gordas Chaudhary. We have two very dear friends of mine, Harshad and Vikram, both professors, and we have a very young and dynamic gastroenterologist, Pallavi, on the panel. So they are going to tell us today how they diagnose and treat a case of IgG4 related cholangiopathy. I'll just give you a brief background of 2 or 3 slides. So this was a very poorly defined term. A lot of names came in: Mikulic's disease, Kuttner's tumor, autoimmune pancreatitis. And then the experts sat down somewhere in 2012, I believe. Yeah, 2012. And came out with the name IgG4 related disease. Now, IgG4 related disease is a disease which can involve any system in the body. So you have pancreatic involvement, you can have biliary involvement, you can have thyroid involvement, bone marrow involvement, any other organ can be involved. And it has various myriad of manifestations. It's a chronic relapsing multi-organ fibroinflammatory disease and presumed to be autoimmune etiology. We don't understand whether it's actually autoimmune or not, but yes, presumed to be autoimmune etiology. And in the same setting, IgG4 related sclerosing cholangitis was named. So this is what we are going to discuss today, IgG4 cholangiopathy. We are not talking about IgG4 related disease in general. We are talking about IgG4 related sclerosing cholangitis. The term was coined way back in 2012. So we have 4 types of IgG4 cholangiopathy. The commonest one is type 1. Type 1 is primarily you have pancreatic involvement, you have autoimmune pancreatitis, leading to stricture of the lower end of CBD, and that constitutes almost 2/3 of all patients which you see. That is the garden variety, 64%. A close differential in such cases will be C ahead of pancreas because you have a lower end CBD involvement. Then you have type 2, which is hilar involvement with lower end CBD involvement. Here again pancreas is involved, or a PSC like picture with a lower end CBD involvement. This is around 13%. Here you think about PSC as a differential. Type 3 and 4 are less common, seen in 10% and 10% each. Type 3 is hilar involvement plus lower end CBD involvement. Again pancreas is involved. So if you see, almost 90% of all cases have pancreatic involvement here. It's only 10% cases where you have isolated hilar involvement and no lower end CBD involvement. Pancreas seems to be normal in such cases. And these are where you have a clear cut, you have a lot of difficulty in differentiating from cholangiocarcinoma. So we are going to discuss one of such case, type 4 today. Straight with the case. Look at the age, 36-year-old male patient. I saw this guy last year. came with painless progressive jaundice for 2 months duration. He had significant itching. There was no weight loss. Diagnosed as diabetes at the age of 25 years. For last 11 years, the patient was on OHA and insulin. The sugar was reasonably controlled. These were the two LFTs he came with, a bilirubin of 3.2 in May 22 and 6.4 in June. Clearly a cholestatic pattern, gamma GT of 842 which raised to 1400 and alkaline phosphatase of 720 and 900. CA19-9 was normal. Ultrasound showed bilateral IHBRD, CBD size was reported as normal. So let me move to the panel. Sir, Dr. Gurdas Chaudhary sir. So you see a hilar stricture, cholestatic pattern. Although tumor markers are normal, this is a young guy. Would you consider IgG4 disease straight away, or would you like to think of other diagnosis here?
I think you have more or less listed it. So cholangiocarcinoma, primary sclerosing cholangitis, if the person had a spleen, portal biliopathy, I think which we often saw. And of course, when we come to cholangiocarcinoma, the only giveaway in this particular case is he's young and he's got diabetes. So given those two and given the recent awareness about IgG4 disease, I think that, it should be on the panel. I think if I look back, I must have missed a lot of patients and misdiagnosed it because IgG4 disease in cholangiopathic situations was a late entrant. I mean, in fact, earlier attention came with the pancreas part of it, with Chari's work on autoimmune pancreatitis. But I think that, I guess now one should be able to do this. The problem often I find is that many of them, you think it should be this, but the IgG4 comes negative, and then what do you do? So those would be some of the issues, but I certainly think we should think about it.
So Vikram, would you order a IgG4 in all such cases, or would you pick and choose, or would you wait for further set of investigations in such cases?
So this is a unique case because he's 36-year-old, and at this age, neither of these differentials is typical. So IgG4 is also classically in older cholangiocarcinoma, while it can happen in young 36-year-old, well, there has to be some predisposition, gallbladder cancer, family history. So again, I will delve more into the history. No, IgG4 is not routine. I'll start with imaging because in this case, based on the age of the patient, I cannot narrow between these four.
Okay, so common things remain common. We first have to think of cholangiocarcinoma irrespective of age, and as Vikram said, delve more into history. So we would like to have more in history and more imaging here. So what imaging and what would be the order of imaging? Dr. Harshad, how would you approach this case? So I've listed 4 investigations here. What would you like first, or would you like all 4? Your take on that?
My first would be to do a CECT because you already done an ultrasound of the abdomen. But when you have diagnostic difficulty, you always sequentially go to the next one. And since this is a young man, you probably have, he has, as Vikram said, any of 4 are possibilities. And one of them is more likely. But as Dr. Chaudhary said, the giveaway is that young age, since when he has diabetes mellitus, and plus the fact that he's on insulin. So that I think is an immunological disorder he already has. So at the back of my mind, and with the increasing prevalence or incidence of IgG4, I would always keep that in mind.
Okay, so a cross-sectional imaging is required, and we want contrast. We agree on that? A CCT abdomen or a MR with a contrast, that's what we would do first. And Dr. Pallavi, would you like to tell us how a CT would show if you do a CT scan on a patient or a hilar with a IgG4? Are there any characteristic things you are looking at, or would you be able to differentiate on a plain contrast CT a IgG4 versus a cholangiocarcinoma?
In IgG4, probably what we will get will be either diffuse or segmental thickening. It will be generally a symmetrical thickening. Whereas in case of cholangiocarcinoma, it will be asymmetrical thickening. There will be no involvement of the surrounding lymph node or any other metastasis in case of IgG4 cholangio.
See, as I said, 90% of cases would also have a pancreatic involvement. This is one case where the pancreas was not involved, but usually when you see a IgG4, you will have some pancreatic involvement. You will have some common bile duct involvement at the lower end. You might see a sausage-shaped pancreas. You might see a PD which is not dilated. So
a
these are the
diffusely
features you
enlarged
would,
pancreas or
absolutely.
irregular
So in this case, the pancreas was normal. This falls into 10% of these cases, but usually a pancreatic involvement will be there. So please look at pancreas the moment you see a hilar stricture also. That also gives you an idea. And as Harshad pointed out, this guy probably has insulin-dependent diabetes, diagnosed at 25 years of age and requiring insulin straight away. So I did not call it IDDM because we don't know why he didn't come to me at 25, he came at 36. But probably he has an underlying autoimmune etiology. So what you see is a concentric bile duct thickening. What is very commonly seen is you can actually see a patent bile duct going through the stricture. So you have thickened bile duct, but you see a streak of fluid, a white colored contrast going through this. This is a common feature. In cholangios, you don't see this. Secondly, the IHBRD is not very pronounced in cases of, not as pronounced as you would see it in a cholangiocarcinoma, just because the stricture is not as tight as you would see in a cholangio. So this patient CT scan showed no mass lesion. There was concentric thickening of bile duct in the hilar region and mild IHBRD. Sir, we like to do a MRCP. You would like to MRCP or you are happy with the CT alone?
No, in hilar lesions and upper bile duct lesions, I think MRCP is probably a better thing to do, so, or at least a complementary test to do.
Absolutely. So that's what we did, sir. We did a MRCP and that showed a hilar stricture, which is actually, if you call a bismuth type 4 stricture. You have involvement, the right posterior, right anterior is seen separately, the left duct is seen separately, then you can see a stricture. But you can see a thin streak of fluid going through the stricture here, and the lower CBD was absolutely normal in this case. Vikram, would you do endoscopic ultrasound in each one of these patients? Would you do a FNAC for each one of them? How would you differentiate where to put a needle in? And please guide us on that.
So
what would be your
Manav,
protocol?
You have done a CCT, you have done a MRCP, but I'm still not clear about the diagnosis. So point is that all I know is that he has a hilar stricture, young male with diabetes with upstream dilatation. I am nonetheless wiser than I was with an ultrasound. I see no mass here, so differential is IgG4 cholangiopathy. And although people follow the HISOR criteria, I would suggest you look up the 2012 Japanese Biliary Society guidelines. They are very useful in practice. And I'll enumerate these for IgG4 sclerosing cholangitis. It is segmental or diffuse thickening or stricturing of the bile duct. Number 2 is raised IgG4. And number 3 is other organ involvement, of which of pancreas is most common. Now the stricture that you show us, if we have IgG4 as a differential, is either type 3 or type 4. Lower end is not very well seen. In this situation, rightfully the pancreas is involved less often, but less often in this case with the largest study by O'Hara meant 81%. So 20% will not have a pancreatic involvement. So now you have an isolated type 3 and type 4, which is less common with absence of pancreatic involvement. And then to diagnose IgG4 sclerosing cholangitis, in this case, I need a tissue. So I will do a IgG4, but that makes it a probable IgG4. I may still offer a resection because cholangiocarcinoma is not ruled out. So and it seems resectable. So before needling, my purpose has to be clear. Even after a negative USFNA, cholangiocancer is not ruled out. It seems to be a resectable tumor, and here I will involve the surgeon. Because it's a resectable disease, whatever it is.
So two things here. See,
Mano, 1 minute.
Please.
Mano, there's one beautiful quotation which I learned at Mayo, and that's, if tumor is a rumor and cancer is the answer, then tissue is the issue. And this case falls very
So I cannot stress more than this. You need tissue. The problem is, if you are suspecting a cholangiocarcinoma, if you are looking at a hilar cholangio, and you want tissue in a resectable case, how will you obtain it? Would you spread the tumor or not? So these are the questions which come to my mind. So when you have pancreatic involvement, it becomes very easy.
So one more thing, before going on to imaging, is it okay if I first order for serum IgG4 levels?
So we did order for serum IgG4. The only problem is the report comes after 4 days. So you admit a patient with a surgical obstructive jaundice and you ask for a IgG4, you can't withhold other investigation for 4 days. So you have to go on with the investigations. IgG4 is awaited. We have already sent it, suspecting IgG4. No, sir, absolutely not. IgG4 can be seen in 80% of patients positive. 20% patients of IgG4 related disease may actually have a normal IgG4. So that gives you a support. And on the other hand, even in a cholangiocarcinoma, you may have IgG4 which is elevated.
So we will look at the IgG4 absolute level, sir. If it is more than 4 times normal, then I am very sure. If it is up to 2 times, maybe here and there. Less than that, maybe not. If it is less than 4, I would do the IgG4 to IgG blood levels, and this ratio, if more than 0.24, suggests that IgG4 fraction is disproportionately raised. Again, all soft clues. Cholangiocancer is not ruled out, but more than 4 times, and in this case, otherwise, then I would look at therapeutic trials and so on and so forth. So, extent of IgG4, sir. So without a tissue, sir, if I have such a lesion with a pancreatic involvement suggestive of autoimmune, then I am definitive. So if I have a isolated stricture and thickening compatible with sclerosing cholangitis, with the rare combination of a sausage-shaped pancreas and no MPD dilatation, then this 1 and 2 will at least warrant a consideration and a therapeutic challenge, because this is exceptionally rare in cholangiocancer. Japanese call it a definitive you have posted here. So a definitive this thing as per their guidelines, and which is okay.
So Vikram has raised a very important point here. See, Japanese is a criteria which we want to follow. So there are 2 diagnostic criteria which we have. We have the HiSAW-T criteria, which was basically proposed for IgG4 related disease with pancreatic involvement. It may or may not apply in an isolated hilar stricture, but the Japanese criteria are very clear. So they have given you 4 settings type. So one is imaging. Second criteria is IgG4, which is high. Third criteria is other coexisting disease. And fourth is histopathology. Definite diagnosis you can make with just 1+3. That means if you have biliary tract imaging which reflects IgG4 related disease, and you have other ancillary evidence like pancreatic involvement, that is enough to make a diagnosis with a raised IgG4.
So now I take you back to the question of USFNA. When I'm doing EUS, even if the CT is normal, if it is autoimmune pancreatitis, we can look and say it is autoimmune pancreatitis. Once you have seen quite a few autoimmune pancreatitis, the look is distinctive. And in the presence of autoimmune pancreatitis, now I have a hilar stricture. And then when you look at the hilar stricture, what is very typical on EUS is, because it's a transmural inflammation, unlike a cholangiocancer, the epithelium is intact. So if you look at this thickened wall, the inner hyperechoic mucosal layer is intact throughout the stricture. It's a diffuse long segment stricture. Then I am reasonably sure that it is a IgG4. Unlike what Pallavi said, I would beg to differ. Very often we find lymph nodes also enlarged in IgG4 in practice, and these are very good targets instead of the obstructed bile duct itself. FNA from a obstructed bile duct risks ascending cholangitis in these patients in whom steroid is on the table. And if the cholangiocancer is a resectable differential, then I would not make a transperitoneal puncture. So a FNA in these cases has to be individualized on table. We consent, but the final decision is taken on table.
Absolutely.
If it is to be done or not to be done.
So that's very important to remember. We have still not ruled out cholangiocarcinoma. Tissue diagnosis is required. One way to get a tissue diagnosis is EUS FNAC. There is one more way you can get a diagnosis without actually thinking about the spread. Harshad, do you do cholangioscopy for these patients?
If you have the modality, I think you would do it, because then the excellent way of looking at the mucosa, and as you have just described, based on the mucosal appearance as well as the plus or no of these vessels, you can make a distinction of cholangiocarcinoma versus IgG4.
So it's a very important investigation in such cases. EUS FNAC, if you have pancreatic involvement, even if you are thinking about a malignancy, there is absolutely no problem doing FNAC, because ultimately if you do a Whipple, you are taking out the area which is from which your needle is going in. In case of hilar, if you are not sure, a good ultrasonologist, endoscopic ultrasonologist will tell you this is unlikely to be a cholangio. You can take a FNAC, but as Vikram said, many a times you may be confused. You may not risk a FNAC if you still have a resectable cholangio as a differential.
Can I make another provocative statement? So we look at pancreas, but if the stricture is in the hilum, and I think of IgG4 sclerosing cholangitis, a EUS guided liver biopsy is also extremely useful, because once the stricture is high up in the hila, the inflammation almost always extends inside. And here, although the sensitivity is low, once the stricture is high, the sensitivity goes up very high, the specificity goes up very high. And you see a biopsy picture very much like a autoimmune hepatitis, but with periportal fibroinflammatory nodules. So the higher the stricture, the more the yield of a liver biopsy. The lower the stricture, also ampullary biopsies and other ancillary techniques can be used. But I have my EOS-FNA scoping. I will take lymph nodes. I will take a liver biopsy. My cholangiocarcinoma remains. I'll take a pancreas if that is enlarged and not jeopardize the patient.
Fair enough. So our endocrinologist was not confident. He said that maybe it's a cholangio, maybe it's IgG4. So we decided to do a cholangioscopy. We went in, we saw the stricture. There were dilated tortuous vessels around the stricture. There was no obvious growth. We took multiple biopsies. No atypical cells were shown in the biopsy. Although we did not see any increase in plasma cells, we did not document IgG4 on the biopsy. Please.
Yeah, we have not excluded cholangiocarcinoma, and there are 3 ducts separated. Doing a cholangioscopy is also risky. I think I would be very scared. You put so much saline during cholangioscopy, and you're not sure whether this is cholangiocarcinoma or not. You'll be
absolutely. I agree with you. Ascending cholangitis is a risk, definitely a risk. But we did all this, and by the time we did all these investigations, the IgG4 came in as more than 4, which Vikram very rightly pointed out right in the beginning. If you have more than 4 absolute value, or more than 4 times elevated.
More than 4 times the upper limit of normal.
So 1.35 is the normal limit.
More than 2 is good, but more than 4 times is practically
confirmatory. This was 3 to 4 times, 3.5 times the upper limit of normal, but yeah, suggestive of IgG4. So, sir, Dr. Chaudhary, sir, so do we have a diagnosis here, or are we still thinking of cholangiocarcinoma?
I think in terms of what we see more commonly, I think cholangiocarcinoma is still something which has to weigh on the mind. And in your biopsy, you didn't actually show inflammatory cells, chronic inflammatory cells, and IgG4 positivity. So a little bit of question mark will still be hanging in my mind. But then the question is that what Vikram was suggesting is that if you are in doubt or whatever, think about a resectability and all that. I think that sometimes that becomes a little too aggressive step. If suppose in retrospect or hindsight you find that it was a simple autoimmune biliopathy. And there we are kind of in a bit of a quagmire. And I would refer the patient to Acharya for a second opinion.
So, Dr. Acharya, what is your opinion on this case? What do you think? Do we have an established diagnosis or not?
I understand what Vikram is saying, that IgG4 levels are very important, right? And that raises the index of suspicion. But we have burnt our finger in both ways. Right. Now, in a Japanese set of patients, your IgG4 4 times elevated is a different ballgame. Now, you have a immunocompromised person here. He is diabetic, right? You don't know his initial IgG status at all. Now, you don't know whether actually there is a true elevation or a relative elevation. I don't know that. I have my questions in my mind. So, I will always go with Gaurdas because we are old people, right? And we will be always suspicious that am I ruling out cholangiocarcinoma 100%? Because IgG4 is more specific if you show a IgG4 positive plasma cells in the
That
tissue.
is true. That is true.
And that
which we
is
did
the
not see in this case.
That is the gold standard of diagnosis. Will you agree with me, Vikram? Is that a gold standard of diagnosis?
No, I would still keep it open. So we will always look at many things in concert.
Yes, many things are always good.
So many things in
out
concert.
Out of all this, IgG4 positive plasma cells in a tissue. Right.
Agreed. But this is a rare thing. It is a 36-year-old male with a isolated hilar and no pancreas.
So this debate itself.
So once you have no pancreas, then as you rightfully said, sir, I would be very, very wary in labeling him as a benign
is not involved here.
Pancreas is not involved, which it should be in at least 80% in isolated hilar. Now he may still turn out to be, but I'll be more cautious in this.
So absolutely, we don't have an established diagnosis as per any criteria. Whether you talk about Visarti.
Manav,
only thing.
Cholangiocarcinoma de novo is rare and more often on PSCs, pre-existing PSCs, and PSCs occurs in this young age. They do not. You don't see in elderly people.
But Manav, my feeling is that more often than not, I get a negative IgG4. So if you have a IgG4 above 4 in a situation where malignancy is improbable because you have done all that biopsy on this thing, I would probably think in terms of giving him a therapeutic.
So absolutely. So question, sir.
Dr. Vikram, you mentioned that IgG4 is more of an extramucosal disease. So don't expect a positive cholangioscopic biopsies Because these are
No, no. So it's the inflammation travels. So even a cholangioscopic biopsy should show you inflammation.
Modality to rule out cholangiocarcinoma.
Yes,
It may not be a good modality to confirm.
You're right,
So
absolutely.
if you have a negative biopsies, negative brushings on cholangioscopy, then you have practically excluded a cholangiocarcinoma.
So absolutely. So just to reiterate, cholangioscopy, the role is to rule in cholangiocancer. There is nothing pathognomic on a spioscope or a cholangioscopy for IgG4 related disease. Nothing pathognomic. In the bile duct, the inflammation is deep by adventitial veins. So intraductal biopsies with spioscope is actually a waste of money. So we look for cholangiocancer. We can never say on cholangioscopy it is autoimmune.
The important thing here to remember is even in cholangiocarcinomas, being serous tumors, your biopsy may turn out to be negative. So that's what we also need to remember, that intraductal biopsies even in cholangios may be negative. So you still have not ruled out, even if you talk about the Hissot criteria or you talk about Japanese criteria, we are only having a probable diagnosis. But that is exactly where the steroid trial comes in. One of the chairpersons, please, sir.
Manu, can we think of PET scan at this juncture, which is a non-invasive test?
So PET scan will be positive. PET scan uptake basically denotes inflammation or tumor. So it will be positive even in a cholangiocarcinoma, it will be positive even in a IgG4 disease, although you may debate that SUVs may be different. SUV may be, but SUV you cannot differentiate these two on the basis of SUV alone. So it may not help. But yeah, the other thing, if you have any other system involvement, that might be picked up on a PET scan.
Right.
Okay, so in such scenarios, when you are still not sure and you have a possible benign diagnosis, you don't want to make the patient undergo major surgery for a hilar cholangio, you can give a steroid trial. The beauty of steroid trial here is the response is almost immediate. Dr. Pallavi, what is your experience in treating IgG4 cholangio with?
Yeah, so either it can be 0.6 to 1 milligrams and the response is seen after 2 to 4 weeks. And then depending upon the response, you can go maximum up to 40 milligrams of steroids. And then taper it over next 6 months and then it can be given to as long as 3 years.
So the response I believe is faster in my experience at least. I don't know, Harsha, do you want to comment?
Generally, in fact, they say within 1 to 2 weeks, you see a fantastic response.
So if you have IgG4 disease, the response is almost immediate. Within a week, you will see some downtrend. You may not have a normal LFT, but some downtrend. I had 30 minutes, we spent 25. It's okay. I'll just fast forward it. Okay. So, all right, sir. So steroids, as Dr. Pallavi said, we start at 30 to 40 milligram per day. As soon as you see the LFT response, you can start the taper within 2 to 4 weeks. There is a controversy about the duration of treatment. I would personally give 6 months, but Vikram, what is your practice? So, Vikram follows Japanese very diligently, yes. So I believe he is going to say more than that. Please.
No, so that's okay. So the way we see it is with PET scan, the response we published on this more than 10 years back. And on PET scan, you see two things. One is the metabolic activity, second is the morphology. So it is the morphology may take a week or two, so what you were talking, but the metabolic activity shuts down in 2 weeks. So the PET goes from 100% to 0 that fast, and that's better. Assessing morphological changes may be more circumscribed or more subject to variation and interpretation. Practically, you would agree with me on that. Then once we are confirmed that we are IgG4 related disease, we continue these steroids for close to a month, 2 months, 3 months, nothing fixed here. Once the response here, we start to taper. And as the Japanese would say, we then maintain at 5 milligram per day. Although this is counter to the Western criteria, most of the relapses which will happen, and now this is data from autoimmune pancreatitis, will happen in 2 years. So in my practice, I would continue a very small dose of 5 milligram for 2 years and follow these. Although the Western people would stop if they relapse rituximab.
So the duration is still not decided. Japanese, as Vikram said, would continue for 3 years.
2 or 3 years?
2 or 3 years.
Very small.
In my own clinical practice, I would stop at Dr. Puri, sir. He has a lot of experience in that, sir. Your comment on that.
Just wanted to make a point. The point in this patient is that he has insulin-dependent diabetes mellitus. So I would avoid steroids and go straight to Ritux. And there's enough data that you don't want to put the patient's sugar steroids. So you go straight to Ritux in this patient.
That's a very valid point.
The advantage of using rituximab is that the relapse rate becomes absolutely flat. So you're not, with steroids, the relapse rate is much higher. So you have to give azoran or something. But if you're using Ritux, then the relapse rate is so much lower that in this patient, the drug of choice, my first choice would be just...
So I agree completely. That's a very valid point Dr. Puri has raised. There is some data that top-down approach may be better than bottoms-up approach here. Start with Ritux and you see the immediate response. Although the classical indication of rituximab is if you have resistance to steroids or you have recurrence after steroid taper or discontinuation. But yes, sir, I take your point. In this case, we may consider, because that's exactly the problem we faced. The patient responded to steroid. Within a week, we saw a downtrend on LFTs. Jaundice settled within 4 weeks, but the diabetes became very poorly controlled. We actually started having problem. We didn't know what to do in such guys. So I guess rituximab in straight would have been a good choice, but we started with steroids. I continued in this case for 9 months. Basically, we take a call depending on the normalization of LFT. So in this case, the normalization of LFT happened somewhere at 3 months. We continued for 6 more months at 5 milligram and then tapered it off. And for 6 months after stopping, as of now, there is no recurrence. I would stop here. Thank you. Thank you for patient listening. Thank you for all the panelists for supporting this.
Just one more point. The story doesn't end here. The problem with IgG4 is that there's enough literature, especially from Japan, coming that these patients are more prone for a second malignancy. So these patients, you don't say you come back, stop seeing me after one. So we had one patient who had developed buccal cavity, lung. So these patients, long term, they develop a second malignancy and they need to be kept on long-term follow-up.
Absolutely, sir, I agree with you. So, वैसे भी clinical practice में तो mostly patients are on long-term follow-up. But yes, in such cases, in this case, there's more a point because malignancy risk is higher. Thank you. Thank you for your patient listening.
As we are running half an hour late, I would request all the speakers to stick to the timings. Coming to the next session, management of HCC, I would like to invite the moderators for the session. Dr. Charles Pennacle, hepatologist, Aster Medicity, Kochi. Dr. Nishant Verma, consultant gastroenterologist, Bikaner. I would like to welcome the chairpersons, Dr. Arun Kumar, senior consultant gastroenterologist, PSRI Hospital, New Delhi. Dr. Aditya, gastroenterologist, AIMS. Dr. Pankaj Singh, senior consultant, M.I.C.E. Saket, New Delhi. Dr. Vineet Ahuja, professor, gastroenterologist, AIMS, New Delhi. Speaker for the first talk, Dr. Ashish Kumar, professor and senior consultant, Sir Gangaram Hospital, New Delhi.
We start with the first talk on the NACL recommendations for hepatocellular carcinoma, the Puri guidelines.
Thank you, chairpersons. I would like to thank Dr. Acharya and Dr. Puri for inviting me here. And these guidelines have been developed under the guidance of Dr. Acharya here. So if I go wrong, he may correct it. So HCC guidelines, there are many guidelines, INASL guidelines, ASLD, EASL, and this is the third edition of the INASL guidelines, which have just been published about 1 week ago in the Journal of Clinical and Experimental Hepatology. And this is the third edition. The first guidelines were published in 2014. The meeting was held in 2013 at the city of Puri in Odisha. And so we named these guidelines as Puri guidelines. The second edition was published in 2019 with the meeting held in 2018. And the third one, the meeting was held last year. And this is the result of this guideline meeting that we published just last week. So what is new in the INASL 2023 guidelines? So this time we have focused mainly on the intermediate and advanced stage, because maximum advancements in the last about 4 to 5 years have occurred in this stage, and there have been many changes worldwide in this stage. And we have also presented in these guidelines a new HCC staging, which we have called as INASL BCLC staging, or the INASL modification of the BCLC staging, which is more in tune with the current practices which are done in India. We have also focused on combination therapies, because now newer evidence point to increased efficacy, superior efficacy of combining especially local regional therapy with systemic therapy, various combination as neoadjuvant or adjuvant therapy. And then there's an increasing role of SBRT, which we have now introduced in the algorithm, because now the data shows that SBRT is a good therapy. And there are many other changes, but I'll focus mainly on some of these. So what is new in the INASL, BCLC INASL staging? We all are familiar with the BCLC staging. We have seen this diagram many times, and this is the modification of the BCLC staging, which is we call as INASL BCLC staging. So I'll go into details. So what have been the shortcomings of the BCLC staging? So in the BCLC staging, there was no mention of the combination therapy like TACE plus systemic ablation. So all we have is the single modality treatment. This is the diagram from the BCLC staging, where you would either give TACE or systemic therapy or best supportive care. There's no mention of combination therapy. The TARE is missing from this algorithm, although there's a good role of TARE in the management. Down staging is not incorporated in the algorithm of the BCLC staging, and BCLC is not very well suited for the LDLT patients. It is much more suited for the DDLT setting. Then in the BCLC staging, all the stage C patients are clubbed together. So whether the patient has portal vein tumor thrombosis or extrahepatic metastasis, it is clubbed as advanced stage C, and then systemic treatment is advised for these patients. And in the decompensated or advanced stage, which there's no option for liver transplantation in the BCLC staging. And also there's no mention of SBRT, and the liver function, they have mentioned that to assess liver function, you can either use LB scoring or child scoring or MELD scoring. So this introduces a lot of heterogeneity across various centers. So for one center, if he is using MELD score, the severity would be different, and at other stage who is using LB score, it will be different. So it introduces a lot of heterogeneity when we are comparing the results. So what the INASL has done, that I'll go stage-wise one by one. So we have incorporated liver transplant criteria into the staging, which was not there in the BCLC staging. So in the INASL, we have said that if the patient fits into the Milan criteria, he is in the stage A, early stage. And if the patient fits into other expanded criteria like UCSF staging, then he fits into the stage B1. So the liver transplant criteria have now been incorporated in the staging itself, which was not there in the BCLC. And when should we do the down staging? So this was missing from the BCLC staging. Although they mentioned transplant, but whether according to staging, should we do down staging or not, it was not there. So in the INASL BCLC staging, we have said that if the patient fits into Milan criteria, we would do upfront liver transplantation. If the patient is of B1, that means UCSF staging, again we'll do upfront liver transplantation. But if the patient presents beyond UCSF criteria, it is preferable to do down staging before subjecting to transplantation. And if liver transplantation is not available, then this patient goes to loco-regional therapy, either by TACE or TARE. So this algorithm becomes much more clearer in the inacil BCLC staging. Then there's now good evidence from India on the role of downstaging. This is the study from Dr. Prashant Bangui group. Dr. Soin was just here. He had presented this. So in this study also, when the high-risk group needs the downstaging, high-risk group are those patients who are beyond UCSF criteria. When should we do TARE? Again, BCLC TARE is entirely missing. But in this, in the inacil BCLC staging, we have incorporated TARE. So for the stage B3, we have actually subdivided the stage B into three groups, B1, B2, and B3. B3 means those patients who have diffuse or infiltrative HCC. So for this group, TARE is definitely indicated. And even for nodular HCC, who are not undergoing liver transplantation, the patient can undergo either TACE or TARE depending on the availability and costs. And definitely many studies have now shown that comparing TACE versus TARE, TARE has got better survival. So if the patient can afford and if the TARE is available, then TARE would be a preferable option. Then stage C is of two types. The BCLC clubbed the stage C into as one, either portal vein thrombosis or extrahepatic spread, which is not logical. So we have subdivided the stage C into two groups, stage C1, which has got portal vein thrombosis without any extrahepatic metastasis, and this group would benefit from TARE or SBRT. And the stage C, which is extrahepatic stage, obviously for them, systemic therapy is the optimal therapy. And can we do liver transplantation stage D patients? The BCLC staging says no, and this stage is doomed for these patients. But we have clearly stated that in terminal stage, where the end stage liver disease, the child C cirrhotic patients, if the tumor is within the transplant criteria, especially if it is within Milan or within UCSF, then these patients can have good transplant outcome. So these patients should be taken up for transplantation if it is available, if the patient can afford. And if the tumor is beyond transplant criteria and the patient is child C, then obviously then these patients will receive breast supportive care. So we have subdivided the stage D also into two groups. And there's now good emerging evidence to show that if the tumor is small and the patients are of decompensated, then obviously these patients are best, the treatment of choice would be liver transplantation in this group. What about the combination therapies? Now there is very good evidence to show that when loco-regional therapy is combined with systemic therapy, then the survival is better. So many studies are there. For example, this study had combined lenvatinib with TACE and in a phase 3 study, and they've shown that combination of systemic therapy with loco-regional therapy has given good option. So this was not there in the BCLC. BCLC, you either give loco-regional therapy or systemic therapy, but there was no option of combining therapy. Here we have said that once you have given the loco-regional therapy, either in the form of TACE, SBRT or TARE, then you can also subsequently give systemic therapy as adjuvant, and because of the good emerging data to show that these are better. What is the role of SBRT? Again, the SBRT, there are many studies which have come up that it is good modality, especially if there is portal vein tumor thrombosis, and also even if there is no portal vein tumor thrombosis, if the tumor is even in the localized in the liver, SBRT has got emerging role, and there are many studies which have shown that with SBRT there is good overall survival, 2-year survival. So SBRT was missing from the BCLC system, but we have incorporated it in stage B2 also. Along with TACE, you can use SBRT, or in the stage C1 where there is portal vein tumor thrombosis, then SBRT has very good role. So the take-home points, INASL HCC guidelines which have been published, and I urge you to use them, and they are the updated guidelines which incorporate the latest systemic and all other studies, and it is suitable for Indian settings, and these are available in JCH website. And the INASL BCLC staging system is a significant improvement over the existing updated BCLC staging system, and I would encourage you to click a picture of that so that it is available in your mobile, and then you can use it in your day-to-day practice as well as in a clinical research setting. Thank you for your patient hearing.
Thank you, sir. Any questions from the audience?
Yeah. So treatment stage migration is there.
So very nice, Dr. Ashish. Sorry, I might have missed it. So where does the role of the current immunotherapy stands? Nivolumab, atezolizumab, bevacizumab?
Systemic therapy. Actually, I have not gone into the details. Now, we have put all the algorithm of systemic therapy, where first line would be atezolizumab or lenvatinib and sorafenib, and in that systemic therapy, we have put it as first line, second line, and all.
What about
options.
nivolumab? What's the status now for
Single
that?
agent nivolumab? So far, the evidence is emerging, but not yet proven. So first line would be the combination of atezolizumab. Checkmate trial was not encouraging. Thank you.
Thank you, sir. I'd like to invite Professor Vivek Saraswat for his talk on systemic therapy in HCC, what's new. Sir needs no introduction.
Thank you, Chairpersons. Good evening, ladies and gentlemen. And thank you very much, Professor Acharya, Dr. Pankaj Puri, for giving me the opportunity. I'll try and briefly cover some aspects of systemic therapy for advanced HCC in the next, what was 15 has now become 12 minutes since morning. So, what is advanced HCC? What are the systemic therapies? Something about society guidelines, atezo-bev, which is now considered the preferred first-line therapy, and some information from real-world experience and comparison to the licensing trial. Combination therapies, I think much of what I had to say has already been covered very well by Ashish, so I will not spend too much time on that. Now, as we all know, we have just heard and seen this updated BCLC algorithm, which says advanced HCC is those with portal vein invasion and extrahepatic spread, which merit systemic therapy. Median survival and the systemic therapy options are listed in this algorithm, and they are available to all of us. I think Ashish has done a great job in modifying and improving these BCLC classification, splitting the advanced HCC group, that is C and D, D being the terminal ones, into C1, C2, D1, D2, and also introducing the concept of combining loco-regional therapy with systemic therapies in these advanced patients. Now, the systemic therapy regimens, I'll just briefly talk about what are the currently used first-line therapy drugs for HCC that on which trials have been published. We are all familiar with the I Am Brave 150 study, which came out in 2020 on atezo-bev and was licensed. Very recently in 2022, Cheng et al. Have updated the data of this, the I Am Brave cohort. The Himalaya studies on durvalumab, tremelimumab, the STRIDE combination, which is all of them, the control group is sorafenib. The Cosmic 312 is cabozantinib and atezolizumab, with again the same control group, that is the standard of care, and the Checkmate 459 nivolumab being compared with sorafenib. And the top line results with these would be that the median overall survival is the best with the atezo-bev combination at 19.2 months. the median progression-free survival or the time to progression, as well as the objective response rate according to MRESIST 1.1 are shown in this table. And for all of these, the median OS is somewhat similar, although Atezo-Bev is a bit ahead. And as well as for the median progression-free survival, and as was just being discussed, nivolumab actually shows the lowest progression-free survival rates, and the objective response rates are relatively low with this as single therapy. Now, recently in JAMA Oncology, what they have done is to look at all these trials with systemic therapy, and they have, like with the European Society of Medical Oncology, introduced the concept of magnitude of clinical benefit, which is objectively scored from 1 to 5, and of this, the Atezo-Bev registration trial, the 2020 study updated in 2022, gives you a very good substantial benefit of 5 out of 5, as does the similar Chinese Oriental study in which the indigenous sintilimab and this anti-vasogenic agent, anti-VEGF agent was used. The others, including the very originals, the SHARP trial, a trial with using centralizumab with the rivoceranib, the new combination with the PD-L1 and anti-VEGFR, as well as the resource trial, which is regorafenib, have shown substantial benefit, while the other systemic therapies show lesser benefit. But I think across the board, all society recommendations clearly endorse that the first line therapy, wherever feasible and where it is not contraindicated, as for example in people who have autoimmune disorders, would be Atezo-Bev for unresectable carcinoma, HCC. And as Ashish pointed out, in the last 3 years, there has been a very large number of guidelines. The Indian nasal guideline has just come out last week. The ASLD, the NCCN, the American Gastroenterology Association, and these European EASL, ESMO, and the ASCO guidelines have come in. And since the Indian guidelines have been dealt with thoroughly, I will not be going into this other than stating that Atezo-Bev is the first line therapy that is recommended in case there are no contraindications for this therapy. And in those in whom this cannot be used, lenvatinib or sorafenib is the first line therapy. The other agents, Tremeli and Durva, is still not available in India, and it is the ASLD has recommended it as a second line therapy, while the other second line therapies, the other TKIs, as well as before and after either immunotherapy, that is immune checkpoint inhibitors, or TKIs, these can be used. And as well as there is mention of pembrolizumab and nivolumab as single agents, but in the second line mode. The JAMA Oncology study has actually summarized what all the guidelines say. These are the standard advanced HCC with various patterns and extent of involvement, the child's PEW A, and in some cases extending to child's PEW B as well, with good performance status, where systemic therapies can be used. So is the patient a candidate for immunotherapy? Contraindications would be those who have autoimmune disorders or those who are allergic or intolerant to these medicines. In them, all these guidelines suggest that you should assess the risk for esophageal bleeding, and if it is high, at least the ASLD suggests that Tremeli Durva should be preferred over Atezo-Bev, while if there is no increased risk of esophageal bleeding, then Atezo-Bev would be the drug of choice. In case on Atezo-Bev there is progressive disease, then one can either try tremelimumab, durvalumab, but more often, according to most of these trials, you would fall back on the second line drugs, that is these TKIs, regorafenib, cabozantinib, or ramucirumab. All these studies have mentioned. Whereas if there is, patient is not a candidate for immunotherapy like autoimmune disorders or previous liver transplant, you use TKIs. And if there is progressive disease on these, then you would go on to the second line therapies, which would include nivolumab plus ipilimumab and pembrolizumab combinations. I spent a bit of time on talking about the real world experience with Atezo-Bev. We had quite an encouraging response with the first line therapy in the original trial that from Finn et al. Recently, and I think Anand is here in the audience, I just saw him a little while ago. This also just a couple of weeks ago, we have published our first Indian experience with the use of Atezo-Bev. The lion's share of cases are from Hyderabad AIG, while a few are also from our center in Jaipur. These were unresectable HCC, 67 patients all told, 86% men, BCLC-C was present in 75%, and interestingly, a large proportion of them were NASH HCC, which at least in some other studies had said that doesn't respond very well to atezo-bev or immunotherapy in general. Also, different from other studies, real-life experiences, in the early part, we did include a small number of patients with CTPC status, although the majority were A and B. The median overall survival we found was about 12 months with a median progression-free survival of 8 months, objective response rate of around 39%, and a disease control rate of 66.1%. Some of these numbers are lower than reported with other real-life experience because possibly of the sub-cohort of CTPC whom we included. And looking at the radiologic response rate, interestingly, a complete response rate was observed overall in about 13%, but mainly in CTPA and CTPB, we got a reasonably good complete response rate. Partial response rate was similar in the overall as well as split according to CTP A and B, and the ALB grade 1, grade 2 followed the CTA, CTPB classification. The stable disease was about 30% in 1/3, better in CTP A, but the results in CTP-C were discouraging. The objective response rate of about 38% and the disease control rate of 66% was primarily because all the patients in CTP-C, the 7 patients we had, showed progressive disease, and they had a very high prevalence of adverse events, while the disease control rate in the AB group was pretty okay. Another study that is worth highlighting is a study in hepatology that came out last year, included 216 patients from 11 centers. Here the dominant etiology was viral B and C, but they were mainly CTP A and B patients, and they showed a good median survival, 14.9, with a progression-free survival as shown here, and a disease control rate of about 73%. Adverse events were notable, as were seen in the registration trial as well. So it appears that even from real-world experience, what we experience in the registration trial, that results are replicated. It is quite safe and efficacious, including in subsets of patients with CTP-B. Comparison of these licensing and real-world trials really show that, in fact, Anand has also done, along with the other members of the group and a multinational study, a systematic review and meta-analysis of over 5,000 patients of 47 published studies of real-world experience, and these, as well as the smaller Indian, as well as the North American European experience, show roughly similar results of disease control rate in about 73 to 75%, and similar results here. So we can say that atezo-bev is replicating in real life what has been shown in registration trials. Adverse events, we have all know about the standard immune response, the standard adverse events, but the immune-mediated liver injury caused by immune checkpoint inhibitors, the ILI-CI, is something that one needs to be aware of. This has to be differentiated from autoimmune and DILI, although histology may not be negative for this. Often the antibodies are negative, and in case this is identified as derangement of LFT happening while patients are on immunotherapy, you grade them into mild, moderate, and severe. Withholding of immune checkpoint inhibitors is sufficient for moderate injury, but with severe injury, 5 to 20 times or higher elevations of beyond the upper limit of normal, these patients would not only require withdrawal of immune checkpoint inhibitors, but steroid therapy may have to be used in moderate to high doses. And once symptoms abate to grade 1 or less, steroids can be tapered. But in a small minority, if there is no improvement or worsening after 7 days of steroids, one may even have to use a higher level of immunosuppression. Interestingly, immune-related adverse events may predict a better outcome because it shows that your immune system is sufficiently activated. Just the last 1 or 2 slides. I don't think I have too much to say about combination therapy. Ashish covered that, except to say that we are one of the centers that is participating in this, the Emerald 3 trials, which is a multi-center, multinational trial in which a combination of durvalumab and termilumab with or without lenvatinib and with a baseline standard of care of TACE. So TACE is being actually given to all patients. Just a couple of slides, if you'll allow me. These are the TACE is the standard of care and given to all 3 arms, and the others you are giving these. So we have to recruit, and we will be seeing these results. Some unanswered questions still remain about Atezo-Bev. How long to continue it in responders? Although we have a good objective response rate of 30, almost 60%, and stable disease PR, CR rate is around 38%. Still, 2/3 of patients are given this, so we need upfront biomarkers or predictors of which patients will really respond to Atezo-Bev, other than the contraindications. Once you have got, say, a complete or a partial response, can we consider them for liver transplant, and how does immunotherapy, how is it to be dealt with when these people are considered for liver transplant? Case reports of people who have had a complete response on immunotherapy going on to liver transplant have appeared, but we need more information on these. And finally, personalized therapy in HCC, where maybe like is happening in breast cancer and other diseases, how far or how near are we to introducing personalized therapy in our patients with HCC? These questions still remain to be answered with systemic therapy. Thank you very much for your attention.
Thank you, sir. Excellent presentation. We can have 1 or 2 questions.
Thank you, sir. The EMERALD-3 trial, after TACE, what duration was given before you started immunotherapies?
It is very much in the recruitment phase. All patients have to be TACE eligible. And thereafter, I think I couldn't show those last 2 slides. There a clear-cut protocol has been drawn up. The total duration of therapy in them is planned for as much as 36 months. And at intermittent intervals, up to 3 to 4 TACE interventions have been planned in these patients.
Yeah. So when we use Atezo-Bev, the cost is a major factor. And we have patients now 1 year who have got stable disease. And going forward, is there any data to say that we can space out the duration, or we can come down on the dose?
I think Dr. Anand Kulkarni from AIG has been addressing these questions and talking about it in various meetings. Once you have stable disease beyond a certain point and there is no further, you are basically waiting for progressive disease to appear, and that remains a possibility. So in these patients, whether other combinations at this late stage can be added on, that if you have actually reduced the therapy and it's not regressing further and you've got a taceable disease now, whether TARE or TACE should be added on to these individuals, that remains. In those in whom you have a good partial response or a complete response, can you step down the doses of immunotherapy being given, mainly because of these cost considerations? These are different strategies that are being tried. But I guess the volume of experience is really not sufficient to endorse any one or all of these. And of course, LT, as case reports, as I mentioned, if a complete response has been achieved, would you consider these people for liver transplant? Are questions that need to be answered.
Thank you, sir.
Thank you, sir. For the next talk, we have Dr. Subhash Gupta. We all know him. He is an eminent liver transplant surgeon, presently at M.I.C.E. Super Specialty Hospital, Saket. He will be presenting on liver transplant beyond Milan and UCSF. How far can we go? Sir, please.
Thank you for this opportunity to speak on transplant for HCC. How far can we go? So we know Milan is a widely accepted criteria, yet recurrence is seen in 15 to 20% of cases. AFP is not part of Milan criteria, and with current advanced imaging, it's not uncommon to see dysplastic nodules which are less than 1 centimeter in size, and should these be included in the Milan criteria? So you can see here a nodule here, and then subsequently 2 years later you can see a full-fledged HCC in the same place. So obviously it's debatable whether they should add to the number of nodules or not. In the Milan criteria, it's not specified. So you can see here again, dysplastic nodule, which after 1 year of follow-up has turned into a full-fledged HCC. At the same time, we know that the more you are liberal with your selection criteria, more the cost is going to be. So, for example, if you stayed a sort of limited number of patients with small cancers, you have better survival. As you kept expanding, your survival would go down, the so-called metro ticket concept. So the first part of the question is, how far should we go? The obvious answer is yes. Then the next part is, where do we draw the line? Extrahepatic disease, portal vein tumor thrombus, should DDLT be different from LDLT, or Milan or UCSF followed in DDLT, which seems rational as this is a scarce resource, so some sort of rationing would make sense. Is portal vein tumor thrombus a contraindication? Till recently we thought it was, but some interesting work from Korea and Dr. Soin's unit have shown that it may be possible in certain selected cases. But we looked at our own experience of portal vein tumor thrombus, and those without portal vein tumor thrombus and with PVT are following sort of local regional therapy, and we found that the survival with portal vein tumor thrombus was not good. So we would not feel comfortable going ahead with transplant with portal vein tumor thrombus. So what are the prognostic factors for recurrence? We are all familiar with these, and many of them have been combined into scores such as morale, retreat, halt, HCC score, and we can use them for a particular patient to see whether that patient should have a transplant or not have a transplant. Now the UCSF criteria is the next one which has been popular, and really Milan and UCSF are both morphometric criteria, and there is really very little difference between the two. And in fact, in a study of explanted livers who were supposedly transplanted within Milan criteria, the explanted liver showed that it exceeded the criteria in 25% of cases. So what about experience with expanded criteria? Milan, UCSF, up to UPTS, French AFP, and Metro Ticket version 2. So these are popular ones, and you can see that the almost comparable 5-year survival is possible. And if in a recent analysis in BMJ Open Access Journal, a meta-analysis showed that Milan, UCSF, and all these AFP and Metro Ticket 2 had similar 1, 3, and 5-year recurrence-free survival, and good 1 and 3 survival. But Milan overall gave the best 5-year survival, and the summary of this is that the tumor should not be greater than 7 centimeters, maximum number of tumors should be less, and AFP should be less than 400. So within this range, we are safe. Has expansion occurred anywhere else? Yes, the Australians have expanded from Milan and gone into UCSF and showed that these patients had similar 5 and 10-year survival rates, and their selection criteria has changed from Milan to UCSF. What about HCC LDLT centers? It is one of the commonest indications for transplantation. Over 40% of transplants in AMC Korea is for HCC. And none of these centers adhere to Milan criteria. Large centers have framed their own criteria, and the ILTS working committee suggested that a 60% 5-year survival would be acceptable. So if you look at the sort of Asian living donor liver transplant predominant centers, you have Hong Kong, you have sort of Taiwan, Asan Medical Center, Tokyo, Kyoto, Kyushu, and most of them, I think, some have used biological markers as well. And I'll give you a summary of what that means. It means that the tumor size should not be greater than 8 centimeters. Number of nodules should be less than 6. If there are more nodules, then AFP and PIPCA should be less than 400. And if there are more than 8 centimeters, then liver biopsy and tumor grade should be either 1 and 2. And under these circumstances, your survival will exceed 70%. Now, we've been looking at a slightly different approach to HCC, which is whether you should be doing upfront LDLT versus local renal first, even if they met the criteria for transplant. And we'll show you some interesting data from our center. So when DDLT was the only option for adult patients, upfront liver transplantation was uncommon. With LDLT, there is a tendency for upfront transplant if it is within the transplant criteria of the center. And the question then arises that if you do local regional therapy, while you are still within the transplant criteria, would you harm the patient? Apart from one study from Toronto where 60% of 301 patients who were eligible for liver transplantation but actually underwent RFA, they had the recurrence pattern which was outside the transplant criteria of the center. So apart from this, there's very little evidence that local regional therapy first is harmful. And there's also growing evidence that when transplant is done for HCC alone and not for advanced accompanying cirrhosis, which per se would not have been an indication for transplant, then recurrence may be higher. So this is another sort of important lesson from the Japanese Transplant Society. Over 80% of patients will undergo local regional therapy before transplantation. They come up with the Japanese 550 and 500 criteria: nodule size less than 5, tumor nodule numbers less than 5, AFP less than 5.4, and recurrence rate is 7.4%. These are really astonishing results and probably the best in the world. In the ILTS meeting this year, one of our fellows applied the Japanese criteria to our cohort and came up with a 12% recurrence rate. So obviously what we feel, and everyone I think we will eventually veer around to, is that even if you are within Milan, you should look at some form of sort of downstaging therapy, even within, and we think resection may be an important modality in that. Multimodality treatment definitely works, and this is an example of a 54-year-old gentleman. You can see there's tumor in the liver going to the portal vein. We initially thought we'll be able to do a resection, but we could not. Then we gave SBRT and sorafenib. This is quite a long time ago, and then AFP became normal. We did a transplant. In fact, there was no viable tumor, and 10 years on, there's no sign of recurrence. There are other advantages with LDLT that may allow for potentially risky local regional therapy. The local regional therapy is generally reserved for patients with chronic disease or those at best with child's age cirrhosis. Theoretically, living donor liver transplantation can be planned if there is there's decompensation following local regional therapy. Initially, this is not popular for, this was, you thought you'll get, you'll harm the patients. TACE was associated with tumor embolization syndrome. TACE seems better tolerated, but they all have very marked anorexia post-operatively. And even SBRT can be applied when there is fear of radiation-induced hepatitis. So we've done many of these things. We've done resection as downstage. You can see here with pulmonary tumor thrombus. Then he went on to have successful transplantation. I'm not going to cover the parts about neoadjuvant immunotherapy. It's been dealt a number of times recently. But what I'll come to straight away is our own experience at CLBS, which is a huge number of cases. In the initial period, it was quite clear that Milan criteria did best. UCF didn't do badly. However, if you bend beyond these two, then you would have poor results. So then that's the time when we changed from upfront liver transplantation to local regional therapy first. So in this, so next few slides, I'm going to share with you what our data on this has been. So from June 2006 to 2022, there were 604 patients of HCC who underwent transplantation. 55 were incidentally detected and 43 died post-operatively. So we had a total of 506 patients for analysis, and 348 underwent upfront liver transplantation, and 158 had local regional therapy first. So obviously this is sort of complete data. So it wasn't done as we do it nowadays, where it's a planned way. So some had actually had more advanced disease. So then we did a matching, propensity score matching, and then we came to about 314 patients which were matched with those who had local regional therapy. So if you look at these data here, then Milan did better than UCSF, and beyond Milan you had sort of 50% overall, 50 months overall survival. But if you compared sort of Milan with UCSF, then Milan did better. And then if you stratified your results according to within Milan, within UCSF, beyond, obviously Milan did much better. And so obviously Milan did much better. Milan and UCSF much better. And if you look at the 506 unmatched versus 314 matched, so before matching, obviously the MELD scores and the CTP scores were different in the two groups, but after matching, apart from the tumor size, they became similar. So what comes, because I think time is running out, so we found that AFP, beyond UCSF, size of the lesion, and lymphovascular invasion were the important factors for adverse sort of affecting recurrence. And if you looked at these overall 314 patients, there was a trend towards higher overall survival in those who had local regional therapy as compared to those who did not have. And recurrence-free survival, again, the trend was higher with those who had local regional therapy as well. And similarly, overall, even within Milan, the trend was towards higher survival with those who had local regional therapy. And similarly, within UCSF, the trend was towards much higher survival. But if you go, when it's beyond UCSF, then even if you did downstaging, the overall survival was not affected at all, whether you did upfront or not. So in conclusion, ladies and gentlemen, UCSF, Milan and Metro version 2 give equivalent results. Milan still gives the best overall long-term survival. It seems unlikely that in DDLT there will be an expansion beyond Milan, and LD centers are more liberal, but certainly not beyond 8 centimeter in size or more than 6 nodules, and AFP, PIVCA, biopsy biology often help in selection of patients at LD centers. Prior local regional therapy may improve overall survival, as shown by our data, even when within Milan or UCSF. And focus should really be shift from expanding the criteria to, as Dr. Saraswat was saying, that we should look at what is best for a patient, so he should have access to every form of treatment before going in for transplantation. Thank you very much for your attention.
Thank you, Dr. Subhash Gupta. Any questions for him?
Thank you for that excellent talk. And when you do local region therapy, how long do you wait before you do transplant, and what is the objective that you are looking at before the transplant?
Yeah, we do not, it's a continuum. So they are, one of the good things about our center is that everything is within one roof. So interventional radiologists, hepatology, it's all together. So they keep being followed up, and if they can be managed by local regional therapy, they will be. But if there's deterioration of liver function or there's involvement of, where the local regional therapy cannot be done, then we would obviously offer them transplant. So it would not really, it's nothing fixed. If they had, say, the decompensation after local regional therapy, then they would go for transplant straight away without waiting for, there's no specified time as such.
Yeah.
Am I making myself clear? It's a continuum of care.
Yeah. So if the size is more than 8 or if the number is more than 6, do you think downstaging you can reduce the recurrence-free survival, or will that be similar?
You saw in our presentation in that once you were beyond UCSF, the survival was similar. I showed that data in the last slide.
So downstaging really doesn't work beyond UCSF?
Yeah, that's right. That is the strong point from our data.
Nice talk, sir. Over the years, we've been seeing criteria only expanding. And gradually the number of lesions, a time has come now with the South Asian criteria, no one is bothered, 6, 7, 8, sizes are increasing. Yet the extra hepatic mets are never more than 1/3 of the HCCs. So are we approaching a simpler state that tomorrow just do a PET CT, nothing outside the liver, don't count the lesions, and do an upfront transplantation?
I think, sir, that you missed what I was trying to say in my talk. I said just the opposite. I said you just
no,
do
I'm wondering
saying
actually
that you do not transplant upfront at all.
No, but the way the people are now 108 months survival, I mean,
No
that's
way.
what I'm surprised. Are we reaching that stage next?
No, we're not reaching any stage. I said HCC should be treated stage by stage. Absolutely. And number one, and as you saw in the data, if your nodules are more than 6, then you will not have good results, even if you downstage.
I think we are running late. Thank you very much, Dr. Subhash Gupta. We close this session now.
So our last session of the day is the dinner symposium. It will be case-based discussion on unresectable HCC. I request the panelists to please come on the stage. Dr. Kaushal Madan, Dr. Neeraj Saraf, Dr. Mano Vadvan, Dr. Sanjeev Saigal, Dr. Piyush Ranjan, and Dr. Shalimar. The moderator for this talk will be Dr. Anand Kulkarni, who is a senior consultant at Hepatology at LBS.
I am from AIG. I am trained from ILBS, I am from AIG now. So, I would like to thank Dr. Puri and
Dr. Anand.
Yes, sir.
So the organizers have instructed to finish off in 20 minutes.
We'll finish off by 15 minutes. And it's a case-based discussion. I have nothing to disclose. There is some... I just bring greetings from AIG, and this is a case discussion, only single case, 57-year-old female, tobacco chewer, known hypertensive on treatment, was evaluated for vague right upper quadrant pain and loss of appetite, and was found to have SOL in the liver. She came to us, BM was 30.5, performed good performance status. We evaluated her because there was an imaging outside which said that there is a large SOL in the liver. We got a PET CT. The largest tumor lesion was 10 by 9.4 into 13.5. The radiologist said it is LR5 and AFP was 1542. Serotic morphology, grade small low risk paralysis, otherwise child A. So the questions here will be, do you need a biopsy for this patient? Anybody can answer, we will just finish one single and answer.
So you don't need a biopsy, you got a cirrhotic liver, you got an LR5 lesion, so AFP is high. So for me, this lesion is HCC, for sure.
Definitely, sir. Any particular indications for a biopsy in HCC, sir?
So in a patient who's got non-cirrhotic liver, where the LIRADS criteria don't fit, you got a lesion which is showing something like an LRM, when I'm not clear whether it's some feature suggestive of a cholangiocarcinoma, or the imaging is not LR5, then definitely we can consider biopsy in that situation.
Sir, as it touched upon ESLD guidelines, the recent ones, LRM and non-cirrhotic HCC, and if it is not classically enhancing, yes, then we do a biopsy, but not all. So how will you approach this patient?
I think one more indication is when you are contemplating a systemic form of therapy, before that it's best to have a tumor tissue, also for trying to find out markers for response to systemic therapy. But so that in those cases also I would do a biopsy.
So the current ASLD also
if I am
says
condemning a patient to systemic form of therapy, not a curative form of therapy, then also I would biopsy.
But the currently available systemic therapy, sometimes we may achieve cure, but as of now they are not found any markers. I am not aware of any markers which have been.
So why would you want to biopsy? Let's say you are considering immunotherapy in this patient. Why? It's a classical HCC on imaging AFP. Then
PDL1 expression or something like that.
So, but the data doesn't support at this juncture looking at PD-L1 or PD-1 receptors as a marker. But yes, for research, definitely. Definitely.
Yes, for research, but I think for clinical practice, I wouldn't.
Yeah.
So there was a paper from this IM Brave's subgroup analysis. They have done a tissue biopsy which was published in Nature. They said that the PD-L1 doesn't matter. What actually matters is T cell activity around the tumor. So if that is possible
what
to
Kaushal
assess,
is trying
probably
to tell us is that we don't know what matters. So it may be worthwhile on research basis.
Yes, sir. Absolutely, sir. So systemic therapy or LRT or directly LT for this patient.
So no liver transplant. Local regional therapy is unlikely to be helpful in such a guy because you have multicentric tumor, you have a 10 centimeter large lesion among other lesions. So systemic therapy for
systemic therapy. Any other?
So in the loco-regional, would TARE be an option for him?
Yes. So I agree, no transplant, but loco-regional or systemic therapy.
Definitely.
I think, I would also consider TARE in this patient, and if he has the money, then maybe TARE followed by systemic.
Even a radiotherapy is a good option. Though it's
for such a large multicentric, I'm not sure if SBRT would be.
Which conditions you select SBRT and?
So it's a multicentric tumor involving both lobes. So tear for which lesion and how many?
The largest one probably.
Would it help? Do we have any data on the usefulness? Yeah, I agree. We might go ahead and do a tear, but do we have data that tear helps in multicentric tumors?
Multicentric, there is a large tumor, 13 centimeters. Probably, if you do, probably SBRT or tear based on the comfort of the individual.
So that's a gray zone. We may decide on either. And
it's a dilemma in gastroenterology and hepatology, and we are talking about dilemma.
Such a large tumor, SBRT might not be a very good idea actually. Yeah. So maybe tear plus systemic therapy. That will be the.
Yeah, I agree. More than 8 centimeter SBRT is not a good option.
SBRT will not be you need to have some functional liver reserve to have SBRT.
So any role of systemic therapy, if you had to plan systemic therapy for this patient who has NASH cirrhosis, do you decide the role of any systemic therapy, be it lenvatinib or any other drug, you want to decide based on etiology or it's on the affordability?
So as of now, the recommendations do not suggest that you should discriminate based on etiology, although there is meta-analysis of subgroup data on patients who have NASH-related HCC do not have a survival advantage. But those were only meta-analysis done on subgroups. So the studies were not powered to look at that difference. So the recommendations are not to discriminate between the two as of now. Maybe in future, this might even become a contraindication.
Any other comments? Anything else you look for this patient? If you are planning a local regional therapy and systemic therapy. So do you combine TACE with TKIs usually in clinical practice?
So data would not support a combination of use of TACE plus addition of TKI as neoadjuvant or adjuvant. The available data is actually against use of, say, sorafenib.
For the one which was published in
the tactics trial exactly says that you can combine, in fact, sorafenib plus TACE. The issue is of the timing of using the systemic therapy. If you antedate sorafenib 3 weeks prior to that, and that is where this priming of these non-responsive tumors to becoming more responsive to TACE is there. So the chances of recurrence is reduced, the number of TACE sessions are reduced. If you continue sorafenib 5 to 6 months into the TACE and then carry on with the TACE.
Time to untaceable progression is what they defined, that if you give sorafenib.
The timing, initially we thought the trials which used sorafenib 1 week prior to TACE, they gave negative results, and here in tactics they have used sorafenib 3 weeks before doing the first session of TACE, and that has proved to be useful. Stopping 2 days before and starting 2 days later.
But do you use in clinical practice?
So I personally would use TACE plus TKI, but we don't give a lead-in period with the TKI. We generally do a TACE upfront and start a TKI subsequently. That's what I do in my clinical practice. Although data may not be very supportive of that practice, but that's what we do.
So the theoretical idea behind that is once you do TACE, you are making these tumors more prone to recurrence and more refractory to future sessions of TACE. And giving a sorafenib or lenvatinib before it might help in that.
So, but clinical practice is not based on, if you look at the literature doesn't support. It's only one trial which is shown where you have a specific protocol being used, but then there is not data to suggest use of neoadjuvant or adjuvant, use of drug with TACE.
So I think one of the reasons, you also were suggesting the same thing, one of the reasons why tactics trial did show a survival benefit was because they used a criteria of continuing TACE till the patient had non-TACEable progression. So not the usual M-resist.
They have used a different criteria, the M-resist criteria they have modified, and untaceable lesion has been defined separately, and liver recurrence, separate liver recurrence has not been mentioned as a progression. So
problem with our radiologist, whatever we had discussed, to give a lead period, whatever you said, that the only thing is that when we give a lenvatinib, there is sudden occlusion of all the veins, the arterial supply decreases. So these guys struggle doing TACE, if at all. For smaller is not this patient per se, but our consultants are little skeptical of doing TACE followed by TKI. If you give TACE upfront, that's good. But TKI followed by TACE will be little difficult for them. That's what I have noticed from our colleagues.
But then that is usually the norm. Radiologists don't prefer the patient should be on lenvatinib.
I think
always stop lenvatinib prior to TACE.
So what you're saying is absolutely right. Our radiologists are also not happy. But I think there are some trials now in which the launch trial also they've given lenvatinib right, up to TACE and then done the TACE.
Only 48 hours.
But practically speaking, the intervention radiologists are not happy to do TACE after TKIs.
Combining this systemic therapy with TARE does not have an advantage. That is the understanding which I have with the published literature.
So there was an abstract at ASLD last year on TARE plus nivolumab. That was not with atezolizumab, and there they showed that TARE plus nivolumab was better than TARE alone. But we don't have any data on atezolizumab.
One more RCT which is underway on TARE plus atezolizumab versus TARE alone. And there is one more published recently on Fortis.
I think you got a recent publication in AJG, if I am correct, which shows published, I think, two weeks back or so, which is a retrospective analysis, 2017 to 2019, TARE plus immunotherapy versus TARE alone, where they show TARE plus immunotherapy to be more beneficial than TARE alone. So that data is there, it's published, it's online, it's available.
Question, Anand. So TARE will cost 15 lakhs. Immunotherapy will cost 25 lakhs. And you are treating a patient who has a disease which is likely to be fatal in a few months' time. Would you? I don't know. We are talking about TARE plus immunotherapy. We also have to understand the type of cost we are incurring on the patient, and for what.
I totally agree with you, sir.
Only so the cost versus human life is very different. You spend a lot of money is there, but I agree, for an individual patient, cost probably should not be a concern. Like, you're working in a corporate, I am more worried about patients' cost. But then people who are coming to you definitely are rich. It should not be a problem.
The only option we can do is we can discuss with the patient and family. If they are agreeing, then probably TARE plus immunotherapy or SBRT plus immunotherapy. Or 16 patients trial has been recently shown that SBRT plus immunotherapy is better. So obviously we did not do any biopsy. We did TARE for this patient. There are subtle difference between TARE and SBRT. Basically, both of them are actually considered as a palliative or a bridging therapy. The only disadvantage of TARE is it is very costly compared to SBRT, which is quite economical. But the issue with SBRT is the whole of the liver may be irradiated, or the tumor, probably the amount of the radiation reaching the tumor may not be sufficient. Although it is still contentious, as of now, TARE has good support from America. That's the reason probably TARE has been upfront used. There are several systemic therapy which has come to in recent years, and the superior most, the first line recommended drug is atezolizumab. For what's your choice, atezolizumab or Lenva, and why? I feel that your aim should always be curative. I agree with you, sir. Cost is a hindrance, but if at all, if possible, if I am able to cure the disease, why not? Is always my question for that. So what's your choice for this patient? TARE plus lenvatinib, or just lenvatinib or atezolizumab, and why?
So data would definitely support. Even the guidelines BCLC suggests that atezolizumab is the first line therapy, and next comes the other line therapies. Then when it comes to clinical practice, I think we've got a lot of questions which were raised in the last talk about how much, when to give, when to stop, but then cost is a major issue. You're looking at atezolizumab per session 1.5 lakh, lenvatinib 10,000 per month. Results better with atezolizumab. If my patient doesn't have any financial issues, I'll give him atezolizumab.
But there is one issue. If you see, there are a lot of real-world data comparing atezolizumab with lenvatinib, and overall survival and progression-free survival are same. The complete response, the proportion of patients who achieve complete response might be more in atezolizumab than
the aim
lenvatinib.
We need to cure the disease. I will just so.
So a subset of patients might benefit, but overall survival is going to be the
I'll just come
same.
to this.
Yeah. So I think what Dr. Acharya has raised, in your real life data, the complete response rate was almost 13%.
13%.
Whereas in the meta-analysis it was 2.8%. I think that possibly reflects the real life more than that 13%.
And coming
Maybe
to this,
your opinion on that?
Sir, I would say that I'm not 2.8%. I think I might have missed it. 2.8% is probably RESIST criteria. On M-RESIST, we found it was 14%. Because there is difference between resist and M-resist, and I still feel 10 to 12% achieve complete cure with atezolizumab.
So even
Out of
we've
120
looked at
patients,
our...
we have around 10 patients who had been listed for transplant. So at least for tumor has vanished. Yes, sir.
So even we've looked at our retrospective data of almost like 20 patients which we have treated, and almost the complete response is somewhere around 15% or so. That means tumor's gone on M-resist. So that's there. But then we've got variable cycles. Some patients we have given 6, some even we have got 11, 12. So it's variable.
So can I ask, Anand, although when you talk of complete response, the tumors seem to go or regress on the CT scan. What I am interested is how many months more my patient is living, which may or may not correlate. So what's the answer to that? How many more months of life, median, are we gaining with
Overall survival,
lenvatinib?
median survival in the primary trial was 19 months, sir, compared to 11 months, it's 11 or 13 months is sorafenib. So median survival, difference of almost 6 months.
Your real world, I think, was discussed in...
19.1 months in, 21 months in child A.
Overall,
child,
I think the
OS was 21
the
months.
talk showed, I think, a lead of 2 months, maybe.
OS was 21 months, sir.
Okay.
21 months is quite pretty good.
More than 6 or 8 months of life gained.
Yes, sir.
Okay. Obviously.
But
so in eligible patients, you do gain 6 to 8 months of life.
At least more than TKIs.
More than TKIs.
At least more than TKIs.
You can make the patient eligible for transplant at that time.
As well.
And that is the difference between the cadaveric transplant programs criteria for HCC and living donor transplant. At least there the patient would not be willing for a treatment or to get downstage because he loses his priority for transplant. And that is where the dynamicity of the Indian setting is that you have living donor, you downstage. If you are able to downstage, then you are able to transplant, as Dr. Acharya is saying, that you need to cure the patients ultimately sometime. Absolutely. We are removing the cost from consideration for the for the time being, sir.
So in the meta-analysis which Professor Saraswat also just mentioned, we noted that PFS, ORR, DCR were much better with atezolizumab and with lesser mortality compared to other TKIs. Although when you compare with lenvatinib alone, it was coming to similar, but at least there was similar, much more better PFS with atezolizumab. And this etiology matter, Dr. Sir has already said that it has been published already in JHEP that there is no, it doesn't matter, etiology does not matter, similar to what we noted, the pooled progression-free survival is 7.44 months in viral group versus 5.5 months, which was similar. So what we did for patient, this patient was did TARE, and there has been studies to show that TARE plus atezolizumab, because when you do TARE, there is increased enhancement of the presentation of the antigens. So we give atezolizumab, then the tumor suppression is much better. Probably we may end up in transplant as well. This is the RCT which is underway. So after 3 cycles, we complained of fever, persistent fever, 100, 101 degree Fahrenheit. We did complete sepsis, workup was negative, PET CT had no active tumor or new lesions, but AFP was still around 924. What might be the cause of this patient, persistent fever in this patient? Because we are running short of time. So there are several adverse events which have been noted. The most common ones is hypertension, fatigue, fever is also common. Immune-related adverse events is also common in this patient. 10% of them can develop immune-related adverse event, and fever is one such immune-related adverse event can be noted in these patients. We did autoimmune workup, ANA was positive, IgG was positive. We used short course of corticosteroids and the patient fever subsided. These are the various prevalences which have been associated with immune checkpoint inhibitors associated with autoimmune hepatitis, but fever per se have been reported in case reports at least. So for this patient, after 3 doses and steroid dosing everything, the complete response was achieved, the tumor decreased, that AFP was still 877. Should you transplant? If yes, when, and if not, why?
I think we need to give a lag period. If you, at least 3 months before we take this patient up for transplant. The AFP has been downstage just to 877. I would have wanted it to come down to less than 500 before considering transplant.
So Vikram was trying to highlight that although you may not see a lesion on the CT scan, your AFP tells you that the tumor is still active. And you don't even know where the tumor cells are, whether it's in the liver or outside. So that lead-in period is very important. That cooling off period.
We are also very little worried about the transplant upfront. So we continued therapy as the previous question. They actually recommended to continue until the disease progresses. But average we have seen is around 6 to 12 cycles maximum. We have gone up to 15 cycles till now. And because since their half-life is 19 to 30 days, when the patient achieves a response, we increase the duration, timing between the doses. For this patient, we increase the timing between doses of 5 weeks. So every 5 weeks, she used to come and get the dose done. Later on, she was not keen on transplant, but then she developed edema and ascites. And this is the data on transplant. As you rightly said, the 3 months is the recommended duration between the ICI and the transplant. All these are data on nivolumab, but actually this is also the other study which is published on nivolumab. There is only one case report where they had done transplant after atezolizumab because the patient worsened and developed liver failure. For this patient, further, her brother agreed. His GRW was 0.9. After a gap of 11 weeks, less than 3 months, we did a transplant for this patient. And since we are running out of time, I'll just show the specimen. I don't want anyone to take the pictures. It's a completely necrosed tumor which is seen on image B, and it's complete cirrhotic liver. And all the lesions, there are 3-4 lesions photos which are not put up here. We are trying for publication, so these I not put all the photos over here. This is cirrhotic liver and complete necrosed tumor. For someone asked me that whether is it required for this patient, was it required so much of cost? But yes, the patient has now 4 months after therapy, patient is still alive. She's been following up with 1.5 to 2 years.
Wait for 1 more year.
I will agree. I will wait for 1 more year, sir. But this was not possible if I had sent her home that.
Absolutely, I agree with you. So we did a similar transplant after immunotherapy, and the patient did have a good outcome to start with, but 6 months down the line we had bad tumor recurrence, and the tumor came all over the body except the liver. So that's the reason I'm saying wait for 6 more months.
AFP was 16 when we transplanted. AFP was 16, we don't know.
We have seen extrahepatic recurrences apparently after a successful liver transplant. So that is always a fear.
16, sir, when we transplanted it was 16, 1-6.
See, Anand, the other thing is we need to differentiate between downstaging and bridging. So most of the data which you showed of nivolumab and going for transplant, they were all bridging. They were already within the listing criteria, and they were given nivolumab so as to tide the time till they get the liver. So I think we need to differentiate between bridging to transplant and downstaging. Bridging is probably still, more feasible, and downstaging is probably more difficult.
So, can I make a comment?
Yes, sir.
Yeah, I think very nice presentation, Anand. I think, as you rightly said, each patient is different. So I just wish to share experiences of 2 of our patients. One is again, immunotherapy, 9 cycles, started having fever. I mean, you said it went on with that. He turned out to be having tuberculosis, proven tuberculosis. So I think in an Indian setup, I think that also needs to be kept in mind. We have stopped his immunotherapy. He's right now on ATT, reasonably doing well. But he had a partial response to around 9 cycles. The second one is a more interesting patient. She was hepatitis B related HCC, and we did a tear on her. On tear, she had a progressive disease. We started her on immunotherapy, 16 cycles. After 10 cycles, now her extrahepatic disease is gone. She was left only with intrahepatic disease. We continued it. Now we have done a stase in between, and we have continued with, immunotherapy. So the combination of, what we were saying, loco-regional with immunotherapy, I think can be considered an individual. The problem in our patient is, I think your patient didn't have extrahepatic disease, if I got it right. Our patient had extrahepatic disease, which has gone now, and we were actually debating whether, I think we discussed this last time also. Extrahepatic disease gone, only intrahepatic disease, combination of, as I said, should we transplant? If yes, how long to wait? All those issues, I think, but so every patient, I think, is different.
So I completely agree with you, sir. So just to put the things in perspective, we also have a patient who was started on immunotherapy. The liver lesion disappeared and extrahepatic disease appeared after 4th or 5th cycle.
Adrenal, sir?
Atozobel.
No, adrenals or bones or location?
Bones.
Bones.
Bones. Lytic lesion in bone. He came back with severe pain in the neck. We got a CT done and we saw lytic lesion. So both things happen. These are still early days in evolution of immunotherapy. It may fit individual patients good, but the overall response rate as seen in meta-analysis is no different from lenvatinib or slightly different from lenvatinib. So, but the only advantage of this drug we have to realize is some patients may have complete response. That some patients we still need to identify. So we cannot go gung-ho about this drug that it should be used in everybody expecting a response. You have failures and hits and misses each ways. So early days we need more data before we can give any conclusive.
Absolutely, sir. We had a patient, actually there was a second patient I didn't show here. I showed at Inasal. Complete bone mets, liver mets, 46,000 AFP, and we have sent home and we started him on atezolizumab. We were lucky enough and his AFP has come down to 4,500 now. Bone mets disappeared, liver completely disappeared. Each patient is different. We don't know. We have had our own share of adverse events. We lost the patient to immune checkpoint inhibitor-related autoimmune hepatitis also. So there are several adverse events, rare adverse events.
We lost patients due to autoimmune hepatitis. Neeraj will tell you upper GI bleeds. So we have problems, but yes, it's an interesting drug to watch out for.
But what would be the minimum cycles you'll give in a patient to say that he is not going to respond? And when are you going to evaluate such a patient with a repeat imaging?
What we do in our clinical practice is minimum 3 cycles. And the moment patient starts having increase in lesions, we stop immediately. So that's what we do, and it has happened. Some patients respond, some people have static disease, some people have recurrence while on cycles. So each one is quite commonly seen. A specific experience, 2 post-transplant patients I have used as of now. Both of them had rising AFP and increasing lesion after 4 cycles. Again, 2 patients is very difficult to generalize your data. We may have patients who respond subsequently. Neeraj might add on to it, but maybe transplant may be a setting where post-transplant recurrence may or may not work.
But then
I also used it in one post-transplant patient, and the patient had progressive disease. He didn't reject, that's all, but he had progressive disease.
They don't reject because we give them upfront steroids. The moment we start immunotherapy after transplant, we give steroids to the patient. But as of now, the experience after transplant is not.
But rejection is always a risk. It's always something which we need. Yeah.
Rejection, but I think rejection risk is overstated, but you can, I think, manage the rejection probably. But I only have one patient experience and there was progression. So we put him back on cabozantinib now.
Post-transplant recurrence.
Post-transplant.
Good data. Okay. Thank you, sir.
Thank you, everybody. It's a wonderful audience. We have some music lined up. We'll expect everybody to just go and charge their glasses. And this is going to take about 10 minutes to get this hall going. So get your glasses charged up and we'll see you in 10 minutes.